Welcome to the ONC Tech Forum Data Quality Symposium. My name is Tom Deneen with Kaufman and Associates, and will be assisting with the logistical support for this Zoom session. To ask questions, click the Q&A button at the bottom of your screen. Please use the raise hand function under reactions, and we will unmute your line to verbally ask questions during the Q&A portion of the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. If you need technical assistance during the session, please type the issue into the chat box and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Steve Posnack.
All right, good afternoon, everybody. And I didn't hang up on myself trying to get off mute. Great, so this is ONC's first data quality symposium. So thank you for joining us. I suggested that we call this the everything you wanted to know about data quality in healthcare, but we're afraid to ask. But thankfully, the team went with something more succinct. That being said, we are going to get into the nitty gritty of data quality and what it looks like in healthcare, how it can be improved, efforts that are underway, and the ways in which many of your colleagues out there are doing work day in and day out to improve data quality. So we hope to get your feedback from this session and to have more focused and targeted discussions associated with data quality as well for future iterations of a webinar like this. We have an all-star cast for you today. So first, I want to thank my ONC colleagues and staff for getting all of this together and arranged, as well as to our speakers. These folks bring to the table a broad range of expertise on standards, implementation, and just industry know-how related to data quality. And I think you'll really enjoy the presentations that we've got lined up for you. And as was noted, don't be afraid to ask questions and just make sure they are of high quality. But the other thing here that I was reflecting on in addition to the kind of preparing for these opening remarks is that, you know, across the industries in which we experience our lives, we experience the quality of stuff. And that ranges from meat to maple syrup and a whole bunch of various types of things in between, where we attribute or assign some type of quality to the product or the service. And there are a number of factors that go into, you know, attributing that level of quality that may be assigned to something. And there are a variety of factors. Either it's definitional, it's experiential, there are different dimensions that we use, and it's no different in healthcare as well. And as all of you know, in healthcare, the use case is really important too. And so in some cases, we need super high quality data, and you can figure out what that means. And then in other cases, we may be okay with the quality of data not being so good if the use case can accommodate for that type of quality of data. Oftentimes, which I think is a challenge for all of us as well, we start to use you know, modifiers or descriptors called research grade or some other type of grading attributed to the data. And sometimes that has meaning, and in other cases, it doesn't have any particular meaning aside from we want this data to be complete and accurate and up to date. And those are the various factors that we use in our minds to, you know, again, attribute the level of quality that we're implying or deciding that the data quality should be. So when you think about data quality and the work that you do, we also keep that in mind as a federal agency here at ONC. It's a part of the work that we do for the Health IT Strategic Plan that we administer for our work across all the federal agencies. It's embodied in the work that I'm sure many of you are paying attention to now with respect to the Trusted Exchange Framework and Common Agreement. So network scale and the data quality issues that may result there. It's part of our regulatory processes. We have all sorts of things, for those of you that are familiar with our certification rules, sprinkled throughout, in addition to referencing standards and other types of data quality improvements there. And then we also most recently have included a data quality focused cooperative agreement through our leading edge acceleration projects. And that is a reference on data quality and the US CDI. And so that's an award that we just made as part of this year's cycle It's called Area 2 in our LEAP program. And so the purpose of this new effort is to identify, understand, and assess the quality of USCDI data elements that are collected, exchanged, and used by various health IT systems. So the awardee recipient is Boston Children's Hospital, and they're going to be working on a project called Cumulus Q. I'd encourage you to check out the information that we've made available thus far on the project, but they'll have 2 years to do their work. And again, it's an area where we'll have an opportunity to learn from the areas of research that they're doing and help to identify areas within the USCDI, which is on its 4th version now, to improve data quality and the work underway. So I just wanted to highlight, again, you're going to hear a whole range from the standard space to how you can approach different types of implementation and assessments, all the way through measuring data quality and different data quality frameworks that may exist, in addition to hearing from our partners over at the VA as well. Lastly, we'll have a bit of a panel discussion that will be among our symposium presenters, and I think that will be equally as entertaining as the individual presentations too, because we'll have that mix and real-time discussion. So with that, as you can hear from my quick rundown of the agenda, it is jam-packed today. We appreciate your time, and dedicating for the virtual session here. And without further ado, I'll get off that virtual stage and make sure that we can keep the agenda flowing. So I will turn it over to my colleague, Sarah, from ONC. And please take us away, Sarah, for the rest of the agenda.
Thank you so much, Steve. Today, we're going to start our symposium with perspectives on standards and implementation. So now I will turn it over to our first presenter, Peter Benson. Peter is the founding and executive director of Electronic Commerce Code Management Association. Thank you for being here today, Peter. Go ahead.
Thank you, Sarah, and thank you everybody for having us here today. Standards are important, of course, and data quality is something that we are very passionate about. Can I have next slide, please? This is just a summary, of course. I won't get into this, but basically my position within ECMA was to try to look at how we could create standards for data quality. And it was driven, we were actually created out of groups that were focused on the supply chains, focused on industrial data quality, and a lot of the military activity to do with how data is exchanged between different parties. So I'm going to talk about ISO 8000. It is the only international standard for data quality, but I'm going to dive a little bit deeper into some of the fundamental principles because I'm going to show you it's really not very complicated. And it is, in fact, universal, and I'm going to show you why that is. And next slide. So, and many of our speakers are going to talk about this a little bit, but we have to think about, why do we do this? What is our interest? What do we bring to the table when we improve the quality of data? And we were working with a company that actually did an evaluation of its corporate entities, and they had multiples of them, a very large corporation, and identified a couple of companies that were doing remarkably better than anybody else. So they took a deep dive to find out what was different in these companies than the other ones, and it was data quality. So the question is, why? What is data quality bringing to the table? What difference does it really make? And it came down to trust. That when employees in the company trust the data, they respond more quickly and more decisively. So that's one area we found. It's really that quality of data is correlated to trust. And because we have trust in the data, we act more decisively. And also it allows us to talk more easily amongst the different members of our organization because we believe in the data, in the quality of data. It reduces risk, of course. And then please, let's not forget, we have to comply with regulatory requirements, and there's costly penalties if you don't. Having access to quality data is critical in that respect. Next slide. So ISO 8000 actually deals with portable data. This is a very important characteristic of quality data. And why is portable data important? Well, if you look at the data that you're collecting, particularly in healthcare, I hope in the next 5 or 10 years, when I'm going to really need that data, the software systems will have changed. That's for sure. Operating systems may have changed, but the data will not have changed. I'd like to make sure we have access to my health records because I want to look over a long period of time. So the data portability separates the data from the applications and the platforms from which the data, how the data is created and how it's stored. And it's really critical. And I'm going to talk a little bit about how we do that, and because it's not as hard as you would think. Of course, by having portable data, we can use multiple applications. And that's, of course, really encourages collaboration because each party tends to have software applications they're familiar with, and you want to be able to work across that. And there's another important issue to do with data portability is that you can store it in a way that you can separate it from the software so you have more control. And security is actually easier to apply security across data, which is sometimes it's counterintuitive. You say if it's portable, it can be taken and stolen. Actually, if it's portable, it's actually easier to store and manage and wrap security around it. Okay, so those are the fundamentals. It makes sense. Why do we do it? Let me talk a little bit about ISO 8000. Next slide. Code Management Association, we are a not-for-profit, and part of what we do is we bring together the U.S. companies that have an interest in international standards. And we're particularly focused on industrial data, interoperability, integration, and we are the project leaders for open data dictionaries, ISO 8000, which is data quality, but also more recently, supply chain interoperability and integration. So that's really what we do. And we have a wide membership. We have an international membership. But as far as the standards are concerned, we actually lead the U.S. delegations with respect to the International Standards Organization. And of course, anybody in the U.S. can join the U.S. TAG, the group that participates in these standards. And if you want to join that technical advisor group and actually participate in the development of these standards, and participating is a really good way to get to understand them well. And of course, it's a good way to make sure they suit your purpose. Of course, you have to put up with all the other countries that participate, and that can be challenging. What do you learn? Nothing's ever done until the French have agreed to it. So you have to be very tolerant for other countries as well. Next slide. So these are some of the standards that we deal with, some idea of how they come together. The first one we talk about is formatting date and time. That's really been around for quite a long time. I use that as actually a benchmark. When you look at data that comes in, look at the date. If it's formatted, month, day, year, right? Well, that may have come from the US. If it's day, month, year, no, why would we do that? Right? The ISO format for date is pretty simple. It's basically year, month, day. Adopting international standards gets rid of ambiguity, and that's really what we're looking for. And most of these standards we're talking about are to do with removing ambiguity, and formatting is really important. Think of your phone number. We all use text. Well, text is because our phone numbers are formatted in a way that it's universal across all the systems. It's simply a formatting issue. So a lot of these standards are not complicated, and they deal with how data is represented and how data is moved from one organization to another. How data is stored inside the organization is typically not something we look at. We're really concerned about how data is moved from one organization to another. Next slide, please. So what is ISO 8000 quality data? Well, let's start with quality. Well, there's a standard, ISO 9000. Actually, ISO 9000 is the terminology for 9001, and it defines quality as the degree to which a set of inherent characteristics of an object fulfills objectives. Keep that in mind. Quality, we measure quality by the degree to which it fulfills the objectives, fulfills the requirements. So we didn't go very far from the fundamental definition of quality in data quality. The object we're concerned with is data. That's not hard to do. But I want to make sure we understand that when we look at ISO 8000 data quality, we're not talking about data profiling. Now, when you go on the open market and you look at software that's data quality focused, you tend to find it really just stops at profiling. ISO 8000 does not stop at profiling. It goes beyond that. It wants to make sure the data is semantically and syntactically explicit. That gives us portability. And it wants to make sure the data meets requirements, meets stated requirements. Well, that means you must be able to state your requirements in a way that a computer can understand. So above all else, ISO 8000 quality data must be fit for purpose. There must be a purpose it fulfills. Next slide, please. I want to take one step back. When we started our committee, started working on data quality, there was a huge discussion about information and data. Were they different? In fact, they are in fact extremely different. And there's another committee that was working on the same area and had some very good definitions. But what we were talking about here is that information is the knowledge, the information that you have, that you think about, that's in your mind. You actually fix it into fixed form when you record it, when you write it out. That's the data. Now think of how it works. If you're translating information into data and you're storing data or moving data around, and then you want to reinterpret it back into information, there's lots of opportunities for errors to creep in. So that's what we're trying to avoid, is trying to find a way to take information, translate it into data in a way that's unambiguous and the way that's independent of time and independent of applications. So understanding the difference in information and data is very important. And you're often going to see characteristics of data quality. Well, some of those characteristics are really information quality. Timeliness. Timeliness is not a characteristic of data. It's a characteristic of information. The data is what it is. The fact that it's timely is a fact of how you access the data. Right? Relevance is another dimension of data quality, which is in fact not data quality, it's information quality. So really, there's two different concepts we're dealing with. And in our case, in ISO 8000, we're really focused on the data quality part. So I tend to use the definition of data quality as fixed form into which information is transformed so we can store it and move it. Now, it also maps the copyright law. You cannot copyright information. You can only copyright the fixed form of information, which is in fact data. Next slide, please. So when we talk about data quality, one of the first things we're going to hit upon is this issue of semantic integrity. What are we talking about? Now, in most data, when you store data, you store with attribute value pairs. You have an attribute, date of birth, and then you have a value, which is a date. Fine. The problem is that labels, words, are really poor labels for data because they're easily confused. They have multiple meanings. I'm sure you probably didn't know that a robot was a traffic light unless you've been to South Africa. When I was actually traveling in Johannesburg and Pretoria, I asked how long is it going to take me to get from one to the other. I said, well, it depends on the robots. I started to imagine, was there a science fiction show in town? I was expecting to see these little guys standing on the sides of the streets. No. In South Africa, a traffic light's called a robot. But so we use terms to mean many, many different things. And that, when it comes to labeling data, is a real problem. Next slide. So we use dictionaries. Now, your normal dictionary that you would be familiar with, your either Oxford English Dictionary or Webster Dictionary, if you open up the dictionary, it's alphabetical, and you come to the word cap, and it says there's two different meanings of the word cap. One is a soft flat hat, and the other is a protective cover. Well, those are very different concepts. And then if you're trying to buy something, it's pretty good to know which ones you're talking about. Right. So the letters CAP are actually very poor labels for concepts because we need context to understand what they mean. Well, sometimes that's challenging. When we bring data together from multiple sources, it's very frequent for us to lose context. So then you're going to lose meaning in the data. So we have a solution to that. So what is in a dictionary? Sometimes we call them terminological dictionaries. You have terms, abbreviations, definitions, images. Sometimes you have source and history where the term came from. That's a dictionary. Well, what we did in ISO 8000, we started using what we called open technical dictionaries. And they differ from a normal language dictionary in a very, very simple method. The concepts, the definitions, have numbers. Let me show you how that's done. Next slide. So when we talk about dictionaries, I like to remind people that there's really two different models of creating a dictionary. I actually love this one. There's the British model. And if you ever want to know how the Oxford English Dictionary was actually built, it's a very interesting story. It was built by somebody who was mad. Effectively, they were in prison for the criminally insane, which goes to show, I don't know if dictionaries make you criminally insane or if you have to be criminally insane to create dictionaries. But the British model, the Oxford English Dictionary, and the Webster Dictionary are what we call crowdsourced. It's simply the publishers of the dictionary trying to keep track and keep up with what the market is talking about, with the terminology that's being used today. Now, that contrasts with the French model. The French model is a committee. The committee decides that this word is a French word. In fact, they had a terminology police in France, and it became, and it still is, illegal to use in publicity material, including your business card, terms that are not in the French dictionary. Right? So they went through a whole era of changing the word of computer, had to be made in French, ordinateur, hamburger was not allowed, viande hachée. So all of these words, these English words were creeping into the French language, were purged. We want to keep it pure. Now, of course, you can understand some of the challenges of which dictionary is going to dominate over the other and how language moves. But if you're going to create a corporate dictionary, which is something you're going to have to do for data quality, we would tend to recommend using the British model, not the French model. Too many companies decide to create a dictionary and to dictate to their employees, this is the term we're going to use. Well, you want to be a little bit more flexible than that to get people to use your dictionary, better to document what they're saying and map between them. And I'm going to show you how that's done as well. Next slide. So the Open Technical Dictionary, it's compliant with ISO 22745, and it is so simple. It takes the normal part of the dictionary, which is the terms, abbreviations, definitions, and images, but assigns a public concept identifier. Really easy. So the word cap I showed you before, there are two different concepts that are being defined. The thing you wear on your head and the bottle closure. Each one would have a different concept identifier. The fact that they're described using the same term makes no difference. Typically, they would have different definitions. Of course, that's important as well. Now, by creating dictionaries like this, we also have the ability to create concept maps. Somebody uses this term in their business, somebody else uses a slightly different term. Oh, but they're talking about the same thing. We can create these concept equivalent maps between them. And that's much faster and, in fact, much easier than trying to get everybody to use the same terms. Quite frankly, Babylon proved they weren't good at it, and since then we haven't got any better. So computers are really good at mapping, and there's no harm in having a dictionary with multiple terms, multiple definitions for the same concept. What you're really trying to make sure you've got your hands around is what is the concept, and we do the concept identifier. Now, the model actually, terms have identifiers, abbreviations, all of them have identifiers as well, so it's everything's actually mapped together. Next slide, please. Now, this is not a new concept. Right? So concept identifiers, yeah, that's probably not a new concept, concept identifiers. So concept identifiers are not new concepts, right? Music is a really good example of that, where you're taking something and you're using a notation of a concept that's universal. Engineering uses images. So having a concept dictionary, an open text dictionary, to basically convert your metadata and your reference data to concepts rather than using words or terms to label your data is not very hard to do. So in an open table dictionary, you'll find very simple concepts: table, chair, weight, length, Monday, kilogram. Whatever concept you want to talk about, it's defined, it has a definition, but also it has a concept identifier. And the reason that becomes useful is that, spanner and wrench, they mean the same thing, different countries, different cultures. They have the same number, the same concept identifier. Computers love it. They can talk to each other very easily. Next slide, please. So what we do in the OpenTel dictionary is we collect terminology from multiple sources, from ISO, IEC, those are standards bodies, also but industry terminology from governments, systems, standard development organizations, and corporate terminology. And we pull it all into the OpenTel dictionary. What you're really looking at, and if you think about that, you go, oh, wait a minute, we're going to have tons of duplication. Yes, that's the intent. The intent is if you bring all the terminology into a single model, you can map from one concept to another. I'm going to show you how that's done. It's very simple to do. Next slide. Here's an example of 3 different organizations that have the word bolt for different concepts. And it turns out, and they have dictionaries. These are 3 different dictionaries. By bringing them together, I can say that the SABIC bolt is the same as the Rockwell bolt and same as the STM bolt. By the way, there's another use for the term bolt. It's a unit of measure, a bolt of cloth. So that one's excluded. But these, we've agreed, are all equivalent concepts. Now, what happened was actually quite great, is that SABIC was able to benefit by Rockwell's definitions and by STM's definitions. So their dictionary was enriched because they were able to use the concepts from other dictionaries. So the whole purpose of the OpenTel dictionary is to allow us to map dictionaries together to not only allow us to exchange data from one party to another, not lose the meaning of the concepts. So that's how we create portable data. We make sure that the reference data, code lists, and the metadata are in a dictionary. And that's, by the way, if you think of a metadata registry, which most people who build data models have metadata registries, right? And they say, well, what's the difference between a dictionary and a metadata registry? Well, a dictionary includes both reference data and metadata. So, and again, that's important because if I send you data and I've said, state, but I use the code CA, right? Or city or country, you know what the context is. I give you CA by itself. You don't know if I'm talking about Canada, California, or Computer Associates. But if I have a concept identifier for the reference data, I never get that confused. Next slide, please. This is just, I promise to put a few technical slides in here, at least one. This is a really actually simple data model. It's the data model we use for master data. In the middle of the slide, you have a very important piece, which is the authoritative legal entity identifier. This identifies the legal entity. We use these identifiers for all organizations, government or corporations, and for an individual, their legal entity identifier is the number on their birth certificate, because you do not become a legal entity unless you're recognized by a government. And that's actually part of the definition of legal entity. That means you can go to court. Court of a jurisdiction recognize you because you're recorded in that jurisdiction. So by identifying legal entities using authoritative data, government authoritative data, one of the ways we remove duplicates from supplier master and from organization masters and patient records as well. So in this case, I was looking at some of the work that's being done on identification of patients. It's interesting that birth certificate is actually used in some places and not in others, in some countries and not in others. What's interesting is corporations, organizations, government entities all have dates of birth. They're all created. Now, an organization, a corporation, is born when it's reported in a business registry or registered with the state. Actually, a government agency is typically born out of a legislation, out of a law that's passed, or some other legal legal action that's passed, which also has a record number as well. So in our view of master data, we have the entities at the center of it, and then we have other data associated with them. We have location identifiers, we have product and service identifiers, we have relationships, and all these things come together, and we really leverage standards every way we possibly can. Next slide. So one of the things we do for our members and for most organizations we work with is we do data quality assessments, where we actually go and look at their data. So we get an extract of their data. The first thing we're looking at is this data portable? And how do we know it's portable? We look at the metadata, we look at the reference data, and then we go looking for our dictionary. Pretty important. Now, it doesn't mean you have to reference the open text dictionary. You could send me a spreadsheet, and the spreadsheet could be quality data. As long as in that spreadsheet somewhere, there's a register, a metadata register, and a reference data register. The column names are described, defined, not just names up there. That's not what we're looking for, is what does that column really mean? Same thing for reference data, the code is described. So we look at portability first, and we're looking for the dictionary. And we're also looking for the data requirements. Remember, we have to be able to assess the data as fit for the purpose. Well, what's the purpose? So are we able to describe and identify the data elements that are needed to perform the task? Now, again, it's not complicated. You've seen in your lifetime hundreds of thousands of forms, whether they're online forms or forms you fill in for hotel registration or when you go to a hospital. Those are forms, form fill. Whoever designed that form actually designed the data requirement. And whenever you see a little red, asterisk, oh, this is mandatory, that's optional, that's all of those can be translated into ISO 22745, which is just a nifty way of storing a form fill in a way that computer can understand and process. It's a universal form fill, if you think of it that way. But you need to know what the requirement is before you can evaluate the quality of data. And of course, part of this assessment, we look at data validation plans. Okay, you're collecting data. So are you storing provenance? Do you know where it came from? Do you have the ability to go back and check? Is the data authoritative or is it value added? Where did it come from? How do I know it's? And then, of course, we look at the governance policies that are needed, and we look at how you could make sure that the data governance policies are actually enacted in the data. It's interesting, and ISO 8000 has a part 51, which allows us to translate data governance policies into a computer processable data that we can use to evaluate whether the data is compliant with the policies. So there you have it. It's not very complicated. It's a really great standard. You get it from either ANSI, American National Standards Institute, or from ISO, either one, and it's short and sweet. It's broken into separate parts, but easy to use. Next slide. There you go. And I'll take questions at the end. But if you look at my signature, for example, here we have actually the ALEI, ISO 8000 legal entity identifier. Every corporation, every organization, every person in the world has an authoritative legal entity identifier, and it's globally unique. So in this case, it's US Delaware.ber followed by a number, but it's globally unique, which is interesting as well. Thank you, everybody, and I look forward to answering any questions you may have.
Thank you so much, Peter. Next, we have Dee Davis. Dee is the Vice President of Informatics Conformance and Interoperability at the Sequoia Group.
Hello, everyone. Can you hear me?
You sound great.
All right, perfect. Wanted to make sure. Well, thank you, and thank you for having me, and welcome to our great group here. And a lot of what Peter just presented on will resonate, and I'll try to connect a few dots within the work that I'm talking about here. But the dimension that the Sequoia Project, and for those of you that don't know the Sequoia Project, if you go to the next slide, I'm just going to give you a real quick brief. Who is Sequoia? Because I can't guarantee everyone knows, but if everyone gets just a 10-second, 20-second bite, hopefully that'll help. We've been around since 2012, and we're a not-for-profit, but we've worked to try to advance what I call interoperability. And our newest foray is to try to advance not only data quality, but also the data usability. And they are two separate, distinct things, but very complementary and not opposing in any way. And so this is kind of the root of it. And our board of directors, our membership, have prioritized this topic of data usability. We waffled on calling it data quality or data usability and landed on usability, but that's kind of the root of where this is. So if you go to the next slide, this kind of gives you the how we've advanced, and I'm just going to highlight those things in yellow. In 2018, we created something called Interoperability Matters. So we've been doing this for quite some time, and at that point in time, our leadership prioritized data usability as a primary goal, but we needed to give some time for that to get into a possible, successful scenario. So about 2020, we launched our data usability work group under that interoperability matters structure. We were focused a lot on information blocking or information sharing, as some people call it now, and other things. And of course, with the whole TEFCA and the recognized coordinating entity role that we play, we wanted to make sure that we lined up with those government policies and regulations wherever possible to use those as some possible triggers to pull those organizations that follow those federal guidelines to actually do some improvements that are possible. And then we published an implementation guide, version 1 of that, in December of 2022. So if you go to the next slide, we'll go through quickly these items. Basically, what we've done this year in 2023 was we decided to pull, it's one thing to get the right data to the right place, the right person at the right time, but you need to also make it useful. And my analogy there is lab data. Now, we've not solved it with version 1 guide yet, so I want to be very transparent there, but we started something that will let us take a baby step to then in our version 2 that we're working on to advance that further. So we've been doing this 3 years, 2 years in public comment. We had 266 organizations with 378 subject matter experts kind of contributing things that we call categories of topics. So if you go to the next slide, the pun intended, sequoia trees. We have tall, very high growth trees that are very old. And the way they do that is they interconnect their roots. That's how they become so strong and can grow so tall. So we want to have these data usability in all projects. So kind of thinking about launching a community of practice, bringing folks together to really continue to evolve this work that we call data usability. So we want it to take root. So you get to the next slide. The focuses data usability work group started. They published a version 1. We're trying to make that take root. We don't want it to sit on a shelf and collect dust. We want it to actually be implemented and deployed. And the goal of what was published in version 1 was something that could be implemented in 18 months or less. So most of what we referenced are things that a lot of folks should be doing, or at least thinking about doing the right thing to do. So the taking root part is the feedback loop. We see this as a feedback mechanism to also inform future work in version 2 that we're working on now. But our goal in this community of practice that we're creating is to have roundtables. We're meeting once a month, and we're bringing those folks who come on board as a supporter and an implementer. We're helping sponsor this. We're very happy to have the AHIMA, the American Health Information and Management Association, as our co-sponsor partner for the entire initiative for taking root. And so we're trying to work together, and we just had our inaugural very first data usability summit just yesterday. So if you go to the next slide, this is some of what was shared. Why do you want to do this? I'm going to focus in the interest of time. These slides are going to be available for everyone that's attending, but it's the right thing to do. Think about how it could help reduce clinician burden, how all the different challenges that folks have, these data quality improvements for outcomes, these health IT systems need to be able to harness that data to make those informed decisions, like using artificial intelligence, like using clinical decision support rules. You need good quality data, but you also need to make sure it's available in the right workflows to be able to harness those extra tools and add-ons that bring value into your system. Next slide. The guide that was published, this is the very closed-in Cliff Notes version. If you're old enough to remember Cliff Notes in high school, the guide that was published focuses on these 6 topic categories: data provenance, tracing the changes over time, effective use of codes, how do you effectively use those codes? And we have very small scopes in many of these, maybe just problems, allergies, medications, that information that you really need, the PAMI focus that folks want, the immunizations and everything else. Reducing the impact of duplicates, making sure that there's ways that when data is exchanged between systems, there's some integrity kept on how to identify that, so you can identify it more easily as a potential duplicate. Data integrity, format, and trust, data tagging and searchability, and then effective use of narratives. That's another golden nugget. We want to make sure narrative data moves with the data that's moving today. Folks are doing very good about moving discrete data, but the real information that clinicians make a very much informed decision on is that narrative data that doesn't always flow. So giving all of this pragmatic guidance, thinking about it from provider to provider, public health to provider, or back and forth, provider to public health, and healthcare entity to consumer. And we say healthcare entity because we mean it could be a physical therapy site. It could be, some sort of other place of care, including a CVS or something like that. How do you move the data between a patient or a consumer of that data? Next slide. The focuses that we think of, I've put some value statements. So if you're thinking about talking about this internally, thinking about, does this matter to me and my organization? Here are some value added points. If you're a public health official, these are things that the guide could bring value if you actually implemented or supported somebody as your vendor to do that implementation for you. If you go to the next slide, the provider perspective talks about some value add from every one of those 6 topic categories. So provenance, effective use of codes, all those topic categories that I just mentioned, there is a little piece or slice that would help in every one of those topic categories for a provider to be an implementer of this. Next slide. The vendors, very similar to what I would call provider, but one's more from a user perspective. The vendor is also supporting their customer base. So there's some nuances there, but many of the answers are going to look very much the same. If we go to the next slide. The consumer, these are very important. So there are consumer focused items and all of us are consumers. So I challenge you to at least read that little tiny piece. The whole guide's only 42 pages in total. And these slides give you a lot of cliff notes. So hopefully it'll help you digest it, even though it's only 42 pages. You can scan it pretty easily. If you go to the next slide. HIEs, health information networks. These are the value adds that can be achieved from those organizations. Next slide. Operational and HIM staff. That's, kind of embracing a HEMA and their population. So if you're an HEMA member, these should be sounding, something that would be relevant for your organization and thinking about from your perspectives. Next slide. So what are we going to do to put this into practice? We're building this community of practice. We just had our first summit in person yesterday. We had great energy in the room, a lot of great leaders contributing their volunteer time. There'll be a press release coming out soon, so watch for that. Identifying where we're going to start. So we've started thinking about, how do we set those priorities? How are we going to measure each other? How are we going to report that so that we can show some of that improvement over time? What can we do very quickly? But what is the proper timelines to set expectations for implementation across? Without, everyone needs to do this at their own pace. So we don't want to throw anybody under the bus, but we want to actually set expectations so that folks can all achieve success when they expect it. But tracking that progress, the incremental approach, so doing this over time, not just a one and done as well, thinking about usability in all projects all the time. And then just thinking about those considerations that we could leverage, like the EHR certification program. We built a lot of that information that was required in this guide on that, including USCDI, which federal regulation references, and even future versions of USCDI are continuing to be advanced by those regulations and policy frameworks like TEFCA that we do in partnership with ONC. So just thinking about all that. But we're really having these roundtables where we'll continue convening monthly. So join us if you'd like. Next slide. These are the, again, we're going to be giving technical assistance. We are going to have a testing tool and a testing platform because we want to be testable. And then that community practice, really think about how do we, advance that? What are the needs going forward? Next slide. And this is what makes it distinctive. We want to really convene and think about all stakeholders. All actors have a different way to think about the lab work that we're starting to do in version 2.0. We put some high priority labs in version 1 that everyone needs to consider how they interoperate and how they make that the most useful for their implementations or adopters, but also thinking about how do we take that to the next step. So we were putting together a laboratory tiger team. So there's different things like that we want to focus on to continue to share the pain point, but inform and also contribute this. None of the work that we are referencing is standards we've created. It's standards that we've referenced, but we've not actually tried to create, we've built it off of derivative works. So if you go to the next slide. These are the different levels: supporter, implementer, sponsors. That's pretty self-explanatory. And if you're interested, you'll follow along. Next slide. These are the roadmap through here and the end of the year. We really want to build that community practice, get it to really form and formulate. So going into 2024, we can expand the participation, think about the technical assistance that we can provide, and then really take and start figuring out how this movement's really growing and how to measure that. And then into 2025, continuing to advance that further. Next slide. If you want to know more, here's the URL. Go straight to that website there. Next slide. And if you have any questions at all regarding, this taking root, there's a general mailbox. It's manned by multiple staff. Please send any emails there. And if you want to follow with the current work that we're now developing for version 2.0, there's a hyperlink on this slide. And I'll turn it back over to Sarah then. Thank you.
Thank you so much, Dee Dee. Now we have Stephen Lane. Stephen is the Chief Medical Officer at Health Gorilla.
Thank you so much, Sarah. Can you hear me all right?
You sound great.
Wonderful. Thanks so much. And thank you, Dee Dee, for that great presentation. Dee Dee and I got to spend the day yesterday together in DC, kicking off the data usability taking root project. So it was really very, very exciting to be there. And I'm happy to be here today. So let's go to the next slide. I'm here to bring the clinician, physician, and health information network perspective. I asked the ONC for the opportunity to chime in here because data quality is incredibly important to clinicians across the spectrum of care, and I think it's just worth digging in on that. And then also what we're doing in Health Gorilla is interesting as well. Charlie Harp and I are going to be tag teaming a little bit. I'll be setting up a presentation that he'll be giving next, talking about an actual deep dive into some of our data. So this is my perspective. I'm a primary care physician, clinical informaticist. I've been at this a long time. I know many of you from many years working in the EHR and patient portal and interoperability space. I've been a champion for multiple interoperability initiatives, both in California, where I live and practice, and around the country, and increasingly internationally. I did join Health Gorilla as the Chief Medical Officer a year ago to really dig in and try to help get TEFCA up and running. And we're very excited to see the progress that's being made, nationwide on that. Health Gorilla is a little different in that it does provide both a nationwide health information network as well as a data sharing platform. Only a few of the QHINs are providing platform services as well, so there's going to be some differentiation there. But we are one of the 7 HINs that have been approved for onboarding as a QHIN and are really looking forward to hopefully getting live with TEFCA Exchange later this year. For my part, I'm very committed to improving the quality of the exchange data, because of course, as you've heard from others, this is going to optimize the outcomes and the value of the care we provide. Next slide. So there are many clinical challenges that we face, as clinicians and caregivers and as patients. We are seeing a tremendous increase in data exchange with trillions of transactions yearly and petabytes of clinical data being maintained, by various data holders across the system. So whereas a few years back, people were wondering if we were ever going to get to interoperability, there's no question that we've gotten there, but now we're really faced with these new challenges. How do we integrate this data seamlessly into the workflows as patient care is provided, as population health is served, as we manage our public health needs? Data quality issues are everywhere. Data can be inaccurate, elements can be missing, there are many duplicates. All of this make it very difficult to make decisions, either in the room with a patient or at the population level. There's a lot of unstructured data in healthcare, and sometimes that's a good thing. We don't want everyone filling out forms and checking boxes. The human experience of illness and healing is nuanced and narrative. And we need to find that balance between maintaining unstructured data where it's important and doing structured data entry where we should. And then aligning data with the many evolving standards and terminologies through ONC. I've been very involved in the advancement of US CDI, for example. It keeps changing every year. We've got new standards that are pointed to that come out of the ICD, et cetera, and we need to keep up with that as that evolves. And of course, as we've heard from each of the earlier speakers, there are many different users for this data, and they each have different needs, and we need to keep all of that in mind. On the next slide, I like to speak of the 5 rights of interoperability: getting the right data in the right format at the right time to the right user with the right supporting workflows. The first 3 of those are all about data quality. You have to get that right. And if we can do that, then we can really address the quintuple aim of healthcare. And I can't think of any other tool in our toolkit other than interoperability that will help us to do this. So this is critical to us being able to do what we are setting out to do. Next slide. There's no question that there are many needs for high quality data. And while a lot of people are frustrated by persistent lack of data access, others are really struggling to make use of the data that they have. We've talked about drowning in data for a long time, and there's quite a broad variability of the quality of data that you get through existing interoperability structures that exist. And as I said, different senders, receivers, users have different motivations. Oftentimes today, with the requirements for data sharing, sources of data may be driven primarily by a desire to comply with those requirements, whereas recipients really, as we heard, really need to be able to trust the data if they're going to put this data to good use. And challenges to data quality really limit the value of data. I mean, we're used to this in healthcare. We're used to making decisions with imperfect, incomplete data. But the closer we can come, the more we're going to be able to minimize medical errors, improve outcomes, lower costs, address provider and patient burden. All of these are critically important, and data quality plays right into them. Now, interestingly, while we heard about the ISO standards and amazing international work that's been going on outside of healthcare, there are no established standards for defining or evaluating or quantifying or managing the quality of clinical data. We have a number of efforts underway. You heard about what we're doing in the Sequoia project. We're going to be hearing from the VA and others, but we really need to tackle this as an industry if we want to make progress. So on the next slide, sort of dialing back to the question of what is data quality, and we've heard about the fitness for use or the fitness for purpose, but it's, again, critical to remember that there are many different uses and purposes that we put this data to, many different participants in the exchange and use of health data, and we have to keep all of these in mind. Next slide. As we've heard, from data science, there are many dimensions of data quality that have been described, that people have tried to quantify. This is an incomplete list, but it gets at how complicated this is. On the next slide, I think that what we need in healthcare is really a standard set of health data quality categories, dimensions, and metrics that will allow us to really describe and manage the data that we use all the time. We can't improve something if we can't measure it, and we can't measure it if we're all doing it different ways. I think it's also critical that, one of the things we find when we start to measure this data is that there are opportunities for improvement. And we oftentimes need to inform the data source of the need to improve. It doesn't do any good when you're a recipient to then, it does some good to try to fix it after you've received it. But the best thing is to go back to the source. So we need a standardized and consistent process for informing data sources about problems in the data. And if we can all do that in the same way, it's much more likely that we're going to get people's attention, be able to get that source level correction so that the data that's then passed on is more useful. This way we'll move towards cleaner data from the origin and enhanced efficiencies and effectiveness as it flows downhill. So on the next slide, I'm stealing a little bit of Charlie's thunder. Charlie, as you'll hear, has spent decades thinking about this problem, and he's put together this healthcare data quality taxonomy, which I think is as good as any. I think the important thing is that we agree on one and then we all use it in the same way. So in this case, breaking down into categories of data transparency, accuracy, usability, and conformity, and then identifying 3 dimensions that can be actually measured and managed within each of those domains. And I think this is, it's a good model. On the next slide, it breaks it down a little bit more, sort of explaining. Let's go ahead to the next slide, and you can just go through there we click a few times. Let's get it all out there. Perfect. That's great. But the idea being here that, looking at some high level categories that we can use to break down. And then on the next slide, really looking at specific metrics within each of those. And again, I think we should all come together, under the auspices of ONC, potentially Sequoia, et cetera, and as a community, come up with an agreed upon set of these categories and metrics so that we can manage to them going forward. On the next slide, we know that HHS is giving this a lot of thought. We're here today for the first time, and this is really an historic event, I think. We're going to be hearing from other industry initiatives, the VHA. Steve mentioned the LEAP Award to Boston Children's, very exciting, that we're actually funding an effort to look specifically at the quality of US CDI data, create some benchmarks and metrics for that. But I think there are real opportunities for us to look at how can we leverage ONC Health IT certification to require certain quality metrics out of certified health IT vendors. How can we look to the information blocking rules, saying, it's not good enough to just share the data, but it actually has to be usable. It has to meet certain standards. That's an opportunity for us to look at in the future. TEFCA, as we said, is going to be evolving. It has a technical framework. We can build in data quality and potentially usability standards into that. And of course, as a provider, I know well that CMS, as the largest payer, has the biggest stick with their promoting interoperability, incentives and initiatives, billing requirements, et cetera. So there are lots of opportunities once we decide on what we mean by data quality and how we're going to measure it and how we're going to identify opportunities. We have various tools to try to move this forward. So on the next slide, I'm going to talk a little bit about what we're doing within Health Gorilla to focus on data quality. We decided to really start with just a piece of the data, the laboratory and medication data, because these are so critical to safe and effective care. It's so challenging as a provider to be able to access and utilize this data from multiple sources. We decided to start with focusing on US CDI completeness and conformance, checking to see for each US CDI data element whether that data is present and whether it adheres to the specified vocabulary standards within US CDI. As many of you know, US CDI has many more data classes than these two, but I think we can start here and develop some experience and a model that will allow us to then expand to all of the US CDI data classes and elements, and then continue to grow as those expand over time. So again, the goal is to identify and quantify and remediate data quality issues, to understand how much of this can be done automatically versus requiring human intervention, to develop a really efficient methodology to look both at data which is at rest within a database. Ours is one of many data platforms out there in our ecosystem, but also, as a network, we're very interested in being able to identify and remediate data quality issues as data is in motion, as it's moving in transactions across the QHIN network and the TEFCA framework going forward. And then we really need to identify a sustainable model. How are we going to pay for this? How are we going to build this? How are we going to evolve this over time as the data standards evolve and clinical and data science evolve as well? So this really isn't a project. This is a whole new way, I think, of looking at what we're doing in interoperability by incorporating quality into the mix. So the next slide, I've broken down sort of my own priorities for how to address US CDI data classes. I mentioned we're starting with labs and meds, the rest of the PAMI data. There are other key data classes that are critical to healthcare processes and decision-making. Clearly, having patient demographics and provenance of the data is foundational to all of this work. You need to know, who it's about and where it's coming from. On the next slide, I dig down a little bit more into the labs and the meds. You can see here on the left, there are now 10 data elements within the laboratory data class as of version 4. There were just 4 in version 3. The one we anticipate will be named in the new HTI-1 rule when it comes out. In the meds class, again, we had a number of additions to the elements in the data class when we came out with the USCDI version 4. Those are really important for the reconciliation of meds and for being able to bring together data from various sources to know what is the truth. So again, the evolution of the standard, in this case USCDI, is going to be critical to us being able to get the data to a point that we can really use it. On the next slide, what we did at Health Gorilla was we pulled together a data set from our data platform that we have. We looked at a number of different ways of selecting data for evaluation. We de-identified all of that. We ended up with about 10 million laboratory results for about 92,000 patients, as well as about 600,000 medication records from 55,000 patients. And we sent those over to Charlie and clinical architecture for him to analyze and help us to really understand. And you need to understand that, Health Gorilla as a company has been around for 9 years. They have a data platform with deduplication, with normalization, with a lot of incredible tools. And so this was evaluating after that, after we did what we, could already do. How are we doing, and what does the data look like, and what are the opportunities for further improvement? So on the next slide, as I said, after the break, Charlie is going to be going through and describing the findings and the work that he's done. And I think it's really interesting to see how, what happens when you really look at the data and you really try to improve that quality and understand it. So I'm going to get us to break, hopefully just a little bit behind our original schedule. We've made up some of the time, and let me hand it back to you, Sarah.
Thank you so much. Thank you to our presenters in this first half of our symposium. We are going to take a break until 1:15 Eastern time. So I will see you back here in just a few minutes. Welcome back from the break. For the second half of our presentations, we will be diving into perspectives from real-world observation and best practices. Our first presenter after the break is Charlie Harp. Charlie is the CEO at Clinical Architecture.
Now you can hear me. Thank you, Sarah.
Yes.
Next slide, please. So I'm Charlie Harp. I'm the CEO of Clinical Architecture. And first, let me say that I'm honored to be speaking alongside such amazing industry luminaries with you today. My perspective, if you go to the next slide, is I'm a simple country programmer. I've been developing systems in healthcare for a little over 35 years. I've worked across multiple verticals in healthcare. I started Clinical Architecture back in 2007, and for the last 16 years have been working providing pragmatic solutions around the space of interoperability, data quality, master data management, and things of that nature. So what I'm trying to bring to the table for you today is kind of this pragmatic in the trenches perspective on the very important topic of data quality. Next slide, please. So I always go back to Lord Kelvin, who said, essentially, if you can't describe it in numbers, then you don't know what you're talking about. And so a lot of what we try to do is apply measures to things so that we can identify or understand more about what's actually going on. Next slide, please. So the first thing I want to go back to is something that Stephen touched on earlier. Next slide, please. And that's the idea of the perceived quality of shared data. Back in February of this year, Clinical Architecture conducted a data quality survey. And of the respondents across several market segments, you could see that very few of the people that were polled thought that the data they got from elsewhere was of high quality. In fact, the only thing that was slightly worse than their own perspective on their own quality was how they perceived data coming from other places. And so that is obviously a barrier to people taking in data. If they don't think the data is good, they're going to be less likely to want to do something with it. Next slide, please. The next question that went with that question on the data quality survey was, what is the likelihood that you'll integrate external data into your enterprise? And you can see as you look across the different segments that there is a bit of variability. 30% said they were currently doing it, 29% very likely, 22% somewhat likely. But then you have some scragglers around 20% that said somewhat or very unlikely. Nobody said never because they're smart. But the real question is, anecdotally, if you look at how people integrate external data today, a lot of them are not truly integrating that data. They're taking it in, a human can look at it, but they don't trust it enough by and large to actually incorporate it into their computable view of that patient's data. So hopefully by improving data quality, we can improve that statistic as well. Next slide, please. So my focus here today is to talk a little bit more about the healthcare data quality taxonomy that Stephen introduced in his presentation. We did secure samples from Health Gorilla. We're going to use USCDI version 3 as a evaluation criteria for the two data classes we're looking at. And we're going to look at how the intersection of USCDI version 3 and a healthcare data quality taxonomy could be applied to the samples, see what they look like, and then later or whenever we can talk about what that means. Now, remember, the data we received was not in message format. It was data at rest from a schema. So we didn't do anything around syntax conformance. We're not talking about FHIR or CCDA or HL7. We are really just focused on the quality of the data itself. And this is data that's intended to be shared. Okay. Next slide, please. Once again, this data came from Health Gorilla. This is Stephen's exact same slide. It was 3 cohorts of data. The evaluation I'm sharing with you today is really on the lumped data. It's all 600,000 meds and all 10 million lab records in a data set. When I did the initial analysis, I divided it out by groups. but for the purpose of today and to keep it relatively quick, it's all in one big lump for each one of them. All right, next slide, please. So the evaluation criteria, in case you haven't heard of it, is the USCDI version 3. We are focusing on 2 data classes, medications and laboratory, because that's the data that we have. And we're using the definitions as supplied by USCDI version 3 to essentially gate the quality of the data as we go through this process. And I'll explain that more in an upcoming slide. Next slide, please. So, as promised, when you think about the evaluation criteria like USCDI version 3, I think of it like a gate. So you get data in from another source and you bring it in and do a data quality assessment. If everything in that record meets the required quality gate, then that data is good. That whole record is good and can be included in your data. However, if that data does not meet the quality guidelines, any aspect of that data does not, then you have a situation where you have to either reject the data, ideally giving the source the reason why you rejected the data, or if you can, remediate the data so the data can be included in your data repository or in your clinical view of the patient. Next slide, please. And I'll come back to that later. So going back to the healthcare data quality taxonomy, Stephen talked about it, but keep in mind that a taxonomy is not special. A taxonomy is just an organization of things so that we can look at the data through the lens of the taxonomy and see if it provides insight into maybe why something's broken or see a pattern of qualitative issues so that we can isolate them, so that we can identify where they came from, why they happened, and ideally remediate those issues. So the only purpose of this taxonomy is to help us organize the things that we're seeing. The other thing is when we combine the HDQT and USCDI, every measure that I applied against this data, I did in a very traditional numerator denominator pass-fail way of doing it. There's no fancy, on a scale from 1 to 3. It is very much a did they pass or did they fail, and then what percentage of things passed when you evaluate them on an individual basis. Next slide, please. Now, when I originally put this together with Stephen, I had these categories. I had all of these dimensions as kind of a starting block. For the health and the lab data, I'm really focusing in on a handful of these dimensions. There we go. And so these are the things we're going to be focusing on, whether it's computable, interoperable, complete, valid, and whether the data is relevant and verifiable. And these things are kind of different. And to Peter's point in his presentation, relevant is kind of an information thing. But when we look at the patient data in healthcare, I think there are things that are bigger than the intrinsic quality of a single data attribute. And so some of these things I've folded in because they're very relevant to when we're assessing what's happening with the payload of data we get on a patient. Next slide, please. All right, we're going to start by looking at the medication data quality assessment. Next slide, please. And this is a snapshot of the data we've received. And so you can see we have a med concept, we have a fill status, we have a dose amount, a dose unit, instructions, and an indication. Now, for some of the indications, we actually have SNOMED coded data, but not a ton of them. And since we're doing USCDI version 3, I did not factor them into this analysis, just some of the things required by version 3. Next slide, please. And if you look at the USCDI version 3, and up in the corner, you can see the HDQT, the actual dimensions that we're focused on. And if you apply them to these elements, all of those things that we're looking at are computable. That is, they're available and they're there. The next is whether or not they're complete. Not just them being complete, but the things that make them up are complete. And the next thing is whether or not they are valid concepts. You'll notice for fill status, even though there's no terminology binding, there are 2 sets of valid fill statuses the HL7 and the fire set of data. I use those to kind of validate whether or not that was actual fill status and not like somebody's name like Bob or something, which could have been in there. And the last was whether or not the things that were bound to a code system were actually appropriately wired to that code system and interoperable. So let's take a look at the results. Next slide. So when you look at the results for each of these elements, and I did actually focus on code system as well, because if you're sending coded data in a payload, if you don't have a code system that's understood, you're not sending coded data. So if you look at the code status, you can see that usability and completeness were pretty much together, and you're going to see that a lot. And I have thoughts on whether or not they're one thing, and I have reasons why they're not one thing. But you can see the completeness was there. The validity and the interoperability also seem to go together, but that is not always going to be true. If you look at the med concepts themselves, that field was complete and computable about 90% of the time and coded to RX norm about 83% of the time. If you look at the dose amount, whether it was complete or valid just means that it wasn't a dose combined with an embedded unit and it wasn't a non-numeric value. And you guys can see the rest, whether the dose unit was there, whether it was a valid member of UCOM, whether the fill status was there and it was a valid value, whether an indication was there, and whether the instructions were there. And if you look at these through the lens of USCDI, you can see for version 1 and 2 where the requirements are the same, it just needs an RX norm code, they were about 83%, which the data shows you. For USCDI version 3, considering that everything in the record has to be past the quality gate for the record to be a quality gate, only about 3% of the records in this data would pass the USCDI quality gate. That in a nutshell is the medication assessment. Next slide, please. If you look at lab data is obviously a little different and a little more expansive. Next slide. The data that we received for the lab was the test concept, the status, the result value or result unit and specimen. Now, we did get some non-numeric results. I kind of let them slide as passing as long as they had a value, and I really focused in on the numeric results. I also did a little experiment with this data. As a proxy for provenance, I used an effective date, any effective date, and there were actually several date fields to give me the idea of whether or not it was verifiable information. So I had a date and an observation ID and a result value. And then relevancy, I looked at the panels that were available and assessed whether the panels were lab panels or not. So there was some imaging data, there was some cardiovascular EKG data, and I basically said those aren't what I would consider to be lab data, so I would flag those as not being relevant. And if we look at the USCDI version 3 for lab data, next slide. The same thing applies, except we expand it into transparency and conformity. So if you look at the things that are computable, it's pretty much the test, the result value, the result unit, the specimen type, and the result status. If you go to the next one, which is complete, those could all be complete and their components could be there. The next one is valid. And a lot of these could be flagged as valid. For example, if you have a numeric result, you should have a numeric result value. You may or may not have a unit of measure. And the next one is whether or not they're interoperable. And since I didn't have any codes for the result values, they're coded results, once again, I just focused on the numeric results. And so when and then you apply whether or not the panels were lab panels, and then the last one is whether or not the field had a effective date, because a lab result without a date is kind of a drift, and you can't do a whole lot with it. So let's go to the results. If you look at the results, let's just start with the relevance. About 97% of the 10 million records were actual lab panels and lab results. Of those records, about 99.9% of them had effective dates. There was some small number that did not. When you look at the lab test concepts, 94% of them had concepts for the lab, but only 44.6% of them were coded to a valid LOINC code. The result status was there about 99% of the time, and there were a few scragglers that weren't actually anything other than like Bob. But for the most part, we did really well there. The result values, once again, was present 99% of the time, about 90% of the time. And this is just for numeric results. 90% of the time, it was a valid numeric result. And with result units, it was populated about 80% of the time, and that's for things that were flagged as numeric results. And about 57% of the time, those things were in the UCOM taxonomy. When it came to specimen type was only computable about 5.3% of the time and complete, and there was no code system association. So from a validity and interoperability perspective, they zeroed out. So if you look at this against US CDI, using our rule of thumb down below, you can see that about 44.44% pass 1 and 2, which just required a LOINC code. And if you ignore the fact that they weren't coded to SNOMED and you gave them kind of an ish passing on version 3, you got about 2.2% that when you line everything up, had everything required to pass the US CDI version 3 quality gate. Now, an interesting thing that I did with this data is I went ahead and tried to remediate this data. So I applied our mapping engine. Go ahead and hit the next one. I applied the mapping engine to the data that was there, and I was able to automatically remediate about 77% of the data. And then I tried another thing that was kind of a trick, which is if you've mapped to a valid LOINC code, most LOINC codes imply the specimen type. And if you use and you're not supposed to use this for clinical use yet, but if you were to leverage something like the LOINC SNOMED collaborative map that maps from a LOINC code to specimen types in LOINC, for example, you can proxy a specimen type as a way to remediate the fact that you don't have a specific specimen type. Ideally, if you trust the LOINC code, then you probably trust the specimen type that the LOINC code implies. When you do that remediation, which we can talk on the panel about remediation or mapping, the numbers for US CDI version 3 increase quite a bit. If you go ahead and hit it again, one more time. You go from 44% to almost 72%. And for the version 3 using the proxy, if you feel like that's fair game, then it takes you almost to 15%. Still not wonderful, but it is a way not just to pass remediated data, but also to kind of gut check whether the specimen type and the LOINC code matches, because not all mappings are created equally. All right, next slide, please. So now I want to talk a little bit about some of my observations and looking at the data. And I have a lot, but I'm just going to share a few because of time constraints. The first one, if you go to the next slide, was that by applying the taxonomy to the data and kind of aligning those things against the different types of checks, next, I was able to take a look at coded data, and I was able to see a pattern where if I pass one particular quality check, it's almost like it makes the next one available to me and the next one available to me. And once I hit the interoperable check, it opens up a door where I can do more of an informational check, to Peter's definition, where now that I know what it is, and I can have a normative semantic reference, I can now do things just like, is it relevant? Is it specific enough? And is it consistent with everything that I'm seeing when I look across the patient? From an uncoded data perspective, if you hit it again, the same thing is true. So once I get past the computable gate, I can check to see if it's complete. If it's complete and I have other ancillary data, I can verify that it's correct. Let's say a lab result is within a realistic value range, and then I can validate it. The bottom line is, it was almost like the usability category dimensions were like gates to allow me to get to the next level of validation. And once again, this is just, to me, the application of a taxonomy revealed a pattern, even if it was kind of an obvious one. And that's kind of the goal of something like a taxonomy. It allows me to look at the data and try to figure out how I can fix it and what's going wrong, which takes us to the next slide. Revisiting the whole idea of an evaluation criteria as a data quality gate. If we look at the data, let's take another look back. Next slide, please. At the medication data. Please hit it again. What this means is if any failure gates a record or a piece of information from making it into my view of the patient, then the lowest performing attribute is going to be an anchor on my best performance for that data. Now, if you were to look at this data as it is, you could make the argument that by looking at these steps of quality, please hit it again, you can identify and prioritize the things that are actually stopping you from getting to a higher level of quality data as you progress through this stepwise fashion. And if you go to the next slide. So the conclusions are, I identified a couple of things with USCDI in going through this process. It's a very pragmatic evaluation criteria, and it sets a bar. I think that we have to make sure that we're able to realistically apply it. And I think sometimes we make these standards aspirational, and it kind of goes back to that idea of what is the quality gate and what is the next quality gate going to be, so that I can get my ducks in a row so that I'm ready when the next quality gate comes out. And I think USCDI has done a good job of laying that out for us as an industry. And it's a positive movement as far as I'm concerned. The healthcare data quality taxonomy that we put together for this example, it's not perfect. You know, the proof of the pudding is in the tasting. And I think that as we do more real world evolution, we might evolve the taxonomy. We might come up with other dimensions, more detailed dimensions. But the important is that we start to evaluate data in a way that gives us these insights so that we can do useful things and not just say the data quality is bad. When it comes to lab and med, coded entities are incredibly important, and people always forget that the code system allows me to basically say whether something is valid. And there are code system OIDs, and we should really try to stick to those and not use our own mnemonics and shortcuts for that. Code remediation, I'm not a big fan of changing data in flight. And when you change data, you have to have the traceability and the original data to make sure you don't engage in a whisper down the lane or game of telephone with that data. Whoever receives data should always know where it came from, when it happened, and what it was originally, so they can interpret it the way they want to interpret it and not rely on 14 other people who touched it before them. But code remediation is something that I think is probably okay as long as you keep the original data. As an industry, we need to do a better job of making sure we get the secondary attributes. And this is another thing too, when you're checking things like allergies or really anything, we invented this concept of no known allergies, because somebody looking at data they receive doesn't know whether something's not there because there's nothing to be there, or because somebody didn't send it and there was things to be there. So we should really consider ways that we can indicate that there is no data here that I'm going to give you. Because it will make evaluation of missing data much easier if somebody says, yeah, this was intentionally left blank. So that's another thing. When I was looking at all this data, I thought it was interesting. And obviously, knowing where the data came from and knowing where it's touched and knowing what I'm allowed to use is something that I'm seeing a lot of really great progress being made, but it's something that as we want to meaningfully share data and trust data, it's going to be important. And going back to Lord Kelvin, you know, the more we can understand about the data and understand what's breaking the data, the better we can do at being good, good members of our data sharing community. Next slide, please. And with that, I'm all done. Thank you so much for hearing me out today.
Thank you so very much. Our next presenter is Catherine Lusk. Catherine is the Vice President of Strategic Partnerships at the Texas Health Services Authority. Catherine.
Well, hi everyone. It's my pleasure to follow everyone because they've set the stage for a beautiful story for me to tell. Because all through everyone's discussion with Dee Dee and Stephen and everyone. You've talked about data quality and the issues that we're having nationally with data quality. And I'm going to dig into that a little bit more. Next slide. What I like to think about is the pipes have been laid, meaningful use, and the Office of the National Coordinator and CMS have done a great job in making sure that we're all connected electronically. But the piece that's now missing is the fact that information is not consistently available, right? But AHIMA has long been a champion of trusted data exchange, recognizing that health data is human data. So we really always focus on that this is a human being that we're talking about, not just bits and bytes, but a human being that is depending on this information to care for themselves or to care for their families. It's all family driven. So trusted data is what we really focus on. And trusted data includes consistency in the content, something that you found missing when Stephen talked and Dee talked and everyone talked. The consistency in the data that is received is making a difference, is creating a lack of trust. And trusted data, what people are looking for, what patients, families, clinicians are looking for is for that data to look and feel the same across all electronic health platforms. And standards allow us to normalize that data, don't they? But the adoption of those standards have been inconsistent. So what we do at AHIMA, all of our professionals, all of our members, is we really focus on using our position statements and calibrating all of our discussions and focusing all of our work efforts on making sure that we yet leverage these position statements. So we talk about accurate, complete, consistent, and timely, trusted to care for our loved ones. Next slide. Well, how that makes a big difference? Well, how that makes a big difference is this lack of trust in data is impacting our nation financially and clinically. Health disparity is a negative result that also impacts different sectors of our population. We really work on that at AHIMA. How can we figure out how can we support everyone, not just a pocket of the community? A publication by Julia Milstein is my very favorite one. And what Julia Milstein tells us is that physicians access external medical records in the emergency room. It cuts down the length of stay by an hour. Well, how many of our hospitals have emergency rooms that are overcrowded and they can't see the people that they need to see? So if we could cut off an hour on that information, that would be critical. It also means that those individuals receive less x-rays. So their radiation, their digital radiation is less. That would be key also. And we also find that they're not admitted to the hospitals as often. So there's an impact on the whole healthcare ecosystem when people look at data from external sources and they believe and trust in that data. And also one of the things that's key is that matching on the patient. The ability to match their records across platforms is key, and that's a problem. Patient ID now tells us that organizations on average are spending 110 hours per week resolving patient identity issues, meaning they're overlays, they're duplicates, records are combined, really critical issues that can impact clinical care. And that's not just in hospitals or doctors' offices, that's also with our public health partners. That's one of the things that I've learned at THSA. And 1 out of 3 organizations is spending $1 million annually to match those patients. So if we go back to Julia Milstein's example of using the electronic health information exchange in the emergency room and how it cut costs there and how it helps move patients along, these organizations are doing things on the front end to match those patients so that when those individuals arrive in the emergency room, that care can be delivered expeditiously and those clinicians can access the records. So that's a lot of money, isn't it? Wouldn't you rather spend that $1 million on other things like clinical things like buying MRIs or CAT scans or accurate or getting the right medications to people? I think most organizations would. And 70% of the respondents in this Patient ID Now research said that these individuals receive duplicate tests and duplicate or unnecessary examinations. Once again, we go back to that radiation exposure and that over $1,000 extra for emergency room visits when they don't access external medical records. That's kind of a lot of money, isn't it? So the data quality and matching the patients is driving up the cost of healthcare across the United States. And when I speak to people, I always say, you know, that cost kind of has to flow down. So if it costs hospitals more money and it costs payers more money, then it all flows down to the buyers, you and I, when we pay our insurance premiums. So we all have to think about this and own this issue. And health disparities. I'm going to talk a little bit more about it because we've done quite a bit of research at AHIMA on how can we make sure that we help as many people as possible. Patient matching can be improved through the widespread use of a patient naming convention or standards, regardless of the EHR platform. So I'm going to talk to you guys a little bit more about that as well. But first, next slide. I'm going to talk to you about an example that's near and dear to me here in Texas. This is a friend of mine's brother, and he's given us permission to share his name. And he goes by Michael, but his real name is Rogelio Miguel Toretto. His grandfather and his father both share the same name, and they all three go to the same PCP. So why is this an issue? Well, different people have captured Michael's name in different ways by not following the standard. So there's a duplicate issue with Michael has multiple medical records scattered across wherever he may have been, and he's received treatment in Texas, Oklahoma, Colorado, because, you know, he's like all of us. He takes a vacation. He goes on a business trip. His medical records have been overlaid with his father and his grandfather, creating an even bigger issue because Michael does not want to be on the cholesterol medicine that his grandfather is on or the high blood pressure medicine that his father is on. And I made that up because I don't know what medications Michael's father and grandfather are on. I'm just doing this as a way to kind of let you know. So the Hispanic names are really important for us to be aware as a community how to capture them and how to capture them accurately so that we are all able to match those patients. So that's one of the ways that we here at AHIMA are trying to fight that health disparity example, because we don't want individuals that have Hispanic names to have their medical records not be matching and to have overlays or to not be able to find that critical information when it's needed. And I'm sure all of you can think of different examples of names that have this same sort of issue, or you might have the same issue with yourselves. A big one is with twins or multiple births. So what we did in AHIMA, next slide, is we brought together subject matter experts from all corners of the United States. You know, we're about a 60 to 80,000 member organization, and we pull together. And when we pull together, we look for subject matter experts that can help us figure out what naming conventions do we need to employ and what will make a difference for the biggest community, the most of us. More of us is available. But we also realize that this is going to be a work in progress, because we learn more and we know more as we start. Just like Dee Dee talked about earlier with the Sequoia Project Data Usability Work Group, in AHIMA we have the same philosophy. Let's get started. And as if we get started, we can help people. But if we sit and pontificate, we are not helping our community. So we adopted this AHIMA patient naming policy framework, and just recently we updated it too. So we really look at how can we pull in as much of the community as possible to help with making sure that these standards are accurate. And just to let you know how broad the subject matter experts are that help develop this policy, I told you before, they come from Texas, New York, California, Puerto Rico, all over the United States. But they also come from different disciplines because the HEMA professionals work in hospitals, doctors' offices, public health, payer organizations, vendors, and they work on developing apps. So we bring all of those individuals together and we say, what elements can help you match that patient regardless of where you're receiving the information from? So this is the framework that we've developed. Kind of simple, isn't it? 10 easy rules. Now we have a publication that goes into great depth on each and every one of them. And I'd invite you to take a look at it because it will help you significantly. And the reason that we developed this framework is so we recognize that not everyone's electronic health record or everyone's matching system is created equally. But if you capture accurate data, if the content is accurate, and if the content is consistently captured in a standardized way, all EHR vendors and all apps are able to match on the elements. So that was our focus, not on technology alone, but on recognizing that technology differs by organizations. Now, our primary principle is capture the complete legal name. And what I tell people is that when you go to college or you go to school, you always give your complete legal name because it's important that your academic history follows you. No one wants to repeat college, do they? I don't, and I'm sure no one else does. Well, our healthcare is more important than our college transcript. So making sure that your records travel with you as you travel across the United States requires capturing a complete legal name. And we train our teams. We train our professional members who then push it on down to really talk about capturing the complete legal name. We came up with a distinct naming convention for newborns because we recognize that a name is not always assigned at birth, and those newborns get transferred to tertiary care facilities often when they're premature, particularly. So we have naming conventions that are adopted to those newborns. And then if they have a name when they get to the transferred hospital, they put the newborn naming convention in the alias pool so that they'll be able to pull that information because we want to make sure that that's available. And I talked to you earlier about duplicates and overlays because of multiple births. Well, we also have a naming convention for multiple births, baby A, B, C. And that helps you with your aliases so that you don't merge or overlay those individuals. A long time ago, I worked at a pediatric academic facility, and we had organizations come in and tell us, well, you have a duplicate issue rate. And I would say, no, we don't. We have lots of multiple births. And this is how we account for those multiple births. We followed a HEMA's naming convention, and that allowed those different organizations to safely access our information and not merge those children's records. Well, smart, but we were smart to follow a HEMA's. Prefixes and suffixes, we like hyphens, particularly with our Hispanic population. Sex and gender is important. A single legal name. Now, there's been quite a bit of debate on this, and we're always looking at it. But there are individuals that have mononyms. They have one name. So what we do is we recommend that the name be in the first name and the last name, and that the middle name be left blank. And that allows everyone to match on the individual. We also have policies on unidentified individuals and how to document that and when to update it. We also recommend, and I'm sure all of you guys do as well, adoption of Project USA for capturing the complete mailing address. Now, what happens if you don't do that is that it's very difficult at times if you only capture part of the address to be able to match the patient. So it helps technically if it complete address according to how the postal system would capture it. We also recommend that nicknames, preferred names, and aliases be captured in order as a reference point, so that regardless of the EHR system or the technical system, that you can match those patients. So next I'm going to talk to you about, now once you match those patients, and that's critically important. Next slide. It's critically important that you be able to find those patients, right? But if you follow a HEMA's patient naming policy, you can have a better ability to do that. So what we've done here at Texas Health Services Authority, we host a multidisciplinary vendor-agnostic interoperability collaborative, and the stakeholders drive our work efforts. And what the stakeholders have told us is that there's a problem with inconsistent discharge summary CCDA content, and it's overburdening the clinicians. They don't trust it, and so they still ask for fax paper copies. And we disprove the myth that physicians want a PDF or fax. They don't. They want the information to come clinically into their electronic health record so it streamlines their workflow and so that they can take advantage of the clinical decision support. But because it's not there, there's a lack of trust, and we fall back on phone calls, faxes to fill in that daily care needs. So the next slide. So what we did was we surveyed the community. We surveyed 119 clinicians. Actually, we sent the survey to more, but we received responses from 119 clinicians. And what they told us is that the CCDAs are not helpful. Well, that kind of hurts your feelings if you're in the technology world, that the CCDA, the information that they're getting, is not helpful, causing them to fall back on faxes. But they did tell us critical things. Standardizing how things look is important, because when they're in a hospital or a doctor's office, that discharge summary CCDA looks the same. There's a consistency in the way hospitals capture it. So that went back to the order of the information, how the order of the information is displayed. And it needs to be lean and concise, because the clinicians were telling us that they were getting thousands of pages of CCDAs and it was not concise. So it needed to be more concise. Next slide. So we came up with a recommendation. This is our recommendation, and we vetted this recommendation through our community, and then we vetted it through the EHR vendors that we know practice in the state of Texas, and we vetted it with nationally. So this is how it looks. And then we've asked everyone to implement it. So our community, our stakeholders, our collaborative, multidisciplinary, we ask each and every one of them to implement this, to send the information, and to receive the information, and to use their style sheets when they receive the information to package it in this consistent way so that our clinicians will see things look and feel the same in a standardized, lean and concise manner to help them when they practice at multiple organizations. We recognized when we did this that this was a beginning. I kind of want to go back to what Dee Dee was saying. This is a beginning. This is a way to get started. And we leveraged my HEMA principles. I'm a health information management professional. So as I'm leading these efforts, I always go back to the HEMA principles on data integrity and data quality so that we triangulate on those and make sure that we're meeting those clinical needs. Next slide. So what we did with this, while we shared it, of course, across our community, which is over 100 organizations across the state of Texas, and then we shared it with the Sequoia Project Data Usability Implementation Work Group. And I'm very proud to say that it was included in the Data Usability Implementation Guide recommendation published in December. So all of you out there who's listening, I'd like for you to go to that guide and adopt that, because that's what will help everyone. We also commented on USCDI version 3. And those of you that don't think that someone's looking at those, I'm here to testify they are. So when I commented for THSA on that, someone called me up and said, we really want you to share this recommendation to Sequoia Project. And I said, thank you, we've already done that. And then they also said, well, I would like for you to share this with the HL7 Structured Documents group. I said, well, if you will electronically introduce me, I would love to become friends with them. And I have become friends with them. They we implemented, we talked to them, we shared our recommendations, we shared the findings and the survey. And those fine individuals said, you raised the bar on CCDAs, invited us to participate in their April 27th implementation-a-thon for unhappy documentation. The stakeholders that led this work group, the Standardizing CCDA Adoption in Texas, went to this work group, shared their concerns, shared our recommendation, and they were very, very supportive. They invited us back for April 24th. Once again, that support continued, and it's going for ballot for HL7 in January the 24th. So this is a way that we took the position statement of HEMA on data quality and data integrity. We looked at the documentation that is being transferred when patients are discharged for transitions of care back to the community. And then we use standards to work it through the system to make sure it's adopted across the United States. So we're really, really excited. It's a grassroots effort, but we're moving things forward. All right, so next slide. So healthcare data and quality, trusted data. That's what we're all about, isn't it? It needs to be complete, consistent, and accurate. The connection of patient records supports that completeness. Unless we can connect people, we can't be complete. So I'm going to really encourage everyone to adopt the HEMA's patient naming structure. But data quality also requires that we normalize data across the care continuum. So, and utilize, and when you're visiting with people and you're working on how to move forward, to try to translate that into the pipes are laid, the content needs to be what we need. So my pitch is adopt HEMA's data quality policies, use our naming policy framework, and my pitch for THSA is to please implement our recommendation for a discharge summary CCDA. Next slide. And the last thing I'm going to leave you guys with is health information professionals such as myself. We have extensive knowledge and expertise to contribute to developing policies around data quality and integrity. We lead things like the THSA Interoperability Collaborative. We lead those efforts within our different organizations, in our different disciplines, wherever we may work, hospitals, doctors' office, payers, public health. But by leveraging those policies and leveraging those core competencies, we can contribute greatly to data quality and help make sure that information is trusted and available when it is needed in a timely manner. And that's my sign off. And please let me know if you have any questions. Oh, and date of birth. I think date of birth is considered, is included, Ralph. I just didn't put that on the top 10.
Thank you so much. Our next presenter is Sandy Mitchell. Sandy is the clinical data quality management team lead at the Veterans Health Information Exchange. Sandy. Looks like we've got a small technical difficulty getting Sandy.
Can you hear me now? There we go.
There we go. Thank you so much.
I appreciate it. I want to start by saying that healthcare is messy. Healthcare ecosystem is messy. Healthcare interoperability and data exchanges are messy. And the solution is the quality journey. I'll be your guide today through the VA's Health Information Exchange quality journey that we've been on for 6 years. Watch for the tour flag as we journey through billions of messages, hundreds of analysis, rules, mapping, integration, and EHRs into the land of usability where all clinicians are happy and all patient encounters are above average. Next slide. Next slide. Basically, the VA is focused on becoming a high reliability organization. And that is by improving the quality and reliability of the clinical data exchanges, not only our own internal data and how we disclose it, but the data that's coming in from our participating partners. Because we engage the entire ecosystem. We're not regional, we're national. It's across many HIEs, many EHRs, and it's a transparent process that we've been going through. We develop, monitor, educate, and contribute to the national level when a situation comes up for these objectives. And the standard process is a standard data quality process. Next. Next. We focus on use cases that add value and impact the clinicians and veterans directly. So we start with the clinical outcomes and those type of use cases, specifically by specialty or project. We include the business operations because, as we've just heard, there are many challenges along the way, starting with the patient matching. We go to the patient experience because your patients need to feel that they can trust the data and their data is safe in this exchange process. The end user experience, where the clinician often burns out or is frustrated or makes the pajama notes once they're home at night. The clinical workflow can be directly impacted when the data comes in and is usable, and can even open up outcomes for new care management opportunities or research opportunities. So we look at the entire ecosystem and focus not on the theoretical or the fields that are only important to a specific small group of users. We need to look at what is most impactful. Next slide. So we start at the bottom with those use cases and work toward what the patient needs and what the clinician needs. So this usability and how much data is available and what usability means in certain situations is a wide variety. But we found that just to focus on meeting a certification or meeting a specific standard, that our needs, better put into documents like IGs, are really expanded. It might be how our particular EHR works through deduplication, or how they work through whatever they need to do to get the data ready for all those AI models. Now, it is worrisome because if it comes out of the source, then each receiving institution has a different set of transformations, deduplication rules, that we all could be looking at the same elephant again. But because we have done different transformations, we're not really seeing the same thing. In healthcare, we recognize that every transition that a patient goes through, from the OR to post-op to home, there is increased risk. And I would propose that the data through each of these interoperability transitions, whether it's from an EHR to an HIE to an aggregator to a transformer, that's a lot of business hops. And in each one, there's an increased risk that something will change the intent of the data that's exchanged. Next slide. So our whole goal is to foster this trust. And We all have different data quality metrics, but the important thing is to open up the conversation. So we established thresholds that we would talk about the data with our partners. We communicate that not only in a slide deck, but we provide deliverable that they can get their hands on the data, de-identified using document IDs and other ways so that we have credibility. We started out and people were defensive, and then they realized that we were bringing something to them with curiosity. And we'll be presenting at the NCQA Symposium next month, because if you approach with curiosity, wanting to engage, finding our commonality, because we all want to get to the same place, they've been very open and now have gotten to the place where almost 100% of the time that our partner will say, well, when can you come back? We'll study this, we'll put mitigation planning in place, but we're going to have to know how we did by using your measurements again. So we have a really robust follow-up, and in some cases have been able to show trends over 3 years. Sometimes they go down, which is a surprise, but that's where their lack of awareness that they were losing ground on the data quality, to bring it to their attention, they realized it happened with a bug fix or an upgrade or a configuration change, totally unexpected. But there's no way to regression test every single functionality. So in this discussion, keeping the curiosity at the forefront and not being judgmental, we're all encouraging each other to grow as we travel on this quality journey. Next slide. Next slide. Now, the VA has goals, and all of you work for organizations that have their top goals. So we carefully align what we're doing, because sometimes people just don't understand value. Well, you know, what does that bring to my bottom line? Yeah, good data. So we align with the goals and start with that up front. So for our first goal, just explaining that we support downstream systems, all that dependence on AI and NLP. Those models aren't going to learn what they're supposed to if the data is incomplete and poor quality. Then everybody understands what we're talking about. The goal 2 with the integrated, that we want to be part of the community. We want to understand the full healthcare continuum of our patient. Care management teams can't work in silos. Goal 3, the fact is that when we improve our data, it improves the whole ecosystem. We're all exchanging with the same partners. So we're all going to run across the same things over time. And potentially we can identify a wide scale problem, maybe with a new upgrade or a version or a transition, and you know, early in that timeline, and be a sentinel of national service with the kinds of work all of us are doing in data quality. And the 4th goal, that the VA is modernizing their systems and moving to a clinical data quality auditing, that we work with all of the records that come in. We go through whatever multitude of suite of tools that we're using and determine a score that we can then trigger, whatever triggers are determined on that score for each record. Next slide. So in this journey towards interoperability, this traveling, and I love Charlie's trekking background to his slides, that we want to make sure that we bring up the right information at the right time. We all understand that. And one of the stories I remember the most was there was an ED doc at the VA who had attempted suicide in front of him. So he reached out, as he had been taught, to ask for that CCDA and bring in the information from the local community hospital. He was very frustrated when what he got was a record that said a date and a diagnosis. He went ahead, took the right actions on the patient, and the patient survived. But a couple days later, he had time to go into the local EHR itself, find there was a lot of data. And he asked me, why didn't it come to him when he needed it? And you have to explain about the journey that the data is traveling through, that there's configuration and a local EHR, and then there's an HIE, and then there's how it's consumed when it arrived or displayed at his institution. And he was just baffled about the journey being so complex. Next slide. Next slide. This is to show the inconsistencies that we run into. And sometimes inconsistency is worse than a simple problem, which you can identify and track down. But when we can find that for vital signs, that only 78% part of the time is available. So available to us means whatever point we are at in usability, because we're evolving. So it's available if it meets our usability criteria that we're doing the analysis at that point in time. And the results domain between 40 and 100%. So, you know, sometimes the ranges aren't exchanged, and we bring that to the attention of our source, and they're like, well, you know, but we didn't think it would be important. We're sending the abnormal normal flag, and that should be enough. So sometimes the perceptions at a specific partner might be different than at another. But again, this shows, and each of these PAMPI domains, we looked at between 1 million and 8 million records in the past year. So this is a very relevant, recent kind of analysis that all of you could do. Next slide. Next slide. So just to talk a little bit about usability, and there are so many usability models, and it's such an exciting time that everybody's kind of poking at it, trying to determine what thresholds would be good to use, figuring on the right side some kind of a phasing in of those usability. And again, it should be a united national effort with all of us coming together with what we've done and what we've learned so far. Next slide. And just to attribute the fact that the healthcare data quality framework is great. And we're working with multitude of frameworks and collaborations, one with JP Systems and one with Elevance. So there are a lot of opportunities out there to be involved. Next slide. And we want to continue to support and thank everybody, not only for attending this wonderful webinar with so many different viewpoints, but realizing that as we wrap up this tour, that the journey continues, and wandering fast, wandering slow. I look forward to seeing all of you on this quality journey. Thank you.
Thank you so very much, Sandy. That brings us to our next break. We're going to take a brief break before we jump into our panel discussion that will be led and moderated by John Demore. We will break until 2:30 p.m. Eastern Time. Welcome back from the break, everyone. It's time to start our panel discussion. Our panel will be moderated today by John Demore, owner of More Informatics. Thank you, John.
Awesome. And let's see if we can have our panelists come back on video here and get people all added to the spotlight for things. I'll give just a couple words of intro. No slides on this perspective, and I think that this is going to be a riveting hour to hear people's perspectives as we double click and drill deeper on the aspects of data quality. I've been working in data quality in healthcare for over 13 years at this point. My first publication on data quality came out in 2010 when meaningful use and the common clinical data set, all those things even before USCDI were out there. And this was a glimmer in our eye to say that first we got to digitize all this immense clinical information, and then how can we actually go ahead and turn that into a more usable set of information as well. But to then move forward and to hear what we had in the last 6 presentations earlier today. We had discussions around the abstract and the process of data quality, but we get down to the specifics as well. We talked about labs, we talked about meds, we talked about patient names, we talked about lot numbers for immunizations. This is just a tremendous panel presentations that we had today for it. I just want to say thank you to all 6 of them to begin with, and thank you for giving us this hour to do some digest. For the format of the panel, what we're going to do is I've got some prepared questions. You can continue to put questions into the Q&A as well, and we'll continue to pick those up and try to integrate those as we go along. But the format will be essentially me asking the question. I'll direct the first several questions to 1 or 2, sometimes 3 people on the panel, but then everyone has an opportunity to respond for things. And as we get towards the end, we'll have a little bit more of a jump ball. So we'll open things up to the group and see who wants to respond first on some of these gnarlier questions as we get towards looking at data quality. Just the themes that I took out from the earlier presentations for it. The goalposts are there. We might not always like them, but we've got USCDI, V1, V2, now V3, V4. We've seen progress in terms of being able to set an idea for what we're trying to shoot for, and what does it mean to be higher data quality or more complete for this picture. I'm going to say something that's a little bit controversial to kind of give us a theme for our panel discussion here. Data quality has never been better. 2023, we have the best data quality that we've ever had in healthcare, but it doesn't always feel that way, does it? Which is, we often feel that we have a real opportunity to do better as we see the gaps between those goalposts and where we actually are today for it. And then the other thing, and Didi tells me this all the time for it, is data exchange has never been larger. We are exchanging more clinical records. If you could have told somebody back in 2010, when I first published on data quality, that we'd be exchanging the amount of records that we were today, they would have said interoperability happened, we won. But of course, we don't feel that way, because we see the gap between the potential and the reality for where we set for it. So those are a few themes. I loved what Sandy had in terms of things. Talking about that journey, as I had an opportunity through Diameter Health and Acquired by Availity to work with health information exchanges, to work with provider and payer organizations nationwide for it. Everybody is on that journey. We are all taking steps, and there's more excitement around this than we've ever had before. So with that, I'm going to just kind of start jumping into questions here for it. The first one that I have oriented, Peter, I'll go to you a little bit, and also Catherine for you for the first one here. ISO 8000, lays out data quality. I think, Peter, you did kind of excellent presentation kind of talking through that perspective. And Catherine, AHIMA obviously has the definitions, the dimensions, the characteristics of data quality that they've put out there for it. First for Peter, and for both of you, I'm going to ask you to give 2 or 3 sentences to just give you your best definition of data quality for it. But also for Peter, I'd love, because we had this question earlier, talk about the data quality versus data profiling. What are the nuanced differences between those? And then I'd like both of you to just comment on how is data quality different when you go to healthcare versus other industries for things? Because obviously, starting from ISO 8000, that applies to a lot of different industries, not just healthcare for it. But maybe Peter, you can start, and then we'll go to Catherine.
First of all, there has been a remarkable improvement in the quality data. So you're absolutely right there. What's actually driving it is increased awareness and the ability of individuals to push back against poor quality data. There's nothing like having your data rejected and say, no, I'm not going to accept it, I'm not going to trust that, to say, oh, maybe I need to go back and do a better job. So there's an increased awareness, the ability to see data for what it is and push back against it, which is what we teach in our training courses, how to push back against data that you can't trust, you don't believe in, how to do it nicely, of course. So the awareness was key. As far as ISO 8000 is concerned, as it applies to healthcare, no, the fundamental principles of quality data are universal. Right? And what we talk about in ISO 8000 is portable data. Data portability is universal. Either it is or is not portable. And the second one that ISO 8000 addresses is fit for purpose. How do you measure fit for purpose? Well, you have to be able to describe the purpose so you can look at the quality and see if it is fit for purpose. And again, that brings us to the question of the difference between data quality and profiling. Profiling is a form of data quality, but it's really looking at the mechanics of data itself. It does not look at portability of data, and it does not look at fitness for purpose. It's really focused on formatting. Is it complete? Are you missing things? Is it interpretable? Charlie talked about, missing codes. How do I map that and get those fixed? Those are all typically data profiling issues. And there's some very good and sophisticated data profiling tools out there that can do cause and effect and look at connections between data, and they're great. But it's simply, we need to look at data portability to make sure it is usable outside the application that used to create it. And is it portable over time? You think, not just an application, but over time. And then, of course, it's fitness for purpose. How can you measure it if you don't unable to describe the purpose? So that's the difference. I hope that makes that clear.
I love the takeaways in this, portability and fit for purpose is kind of big takeaways in that definition from a data quality. Catherine, I'd love to kind of get you to lean in here and give perspectives from HEMA and also your experience.
Well, I'm going to lean into what Peter's talking about. Healthcare is changing, and people are seeking care in different divergent ways and different places of care delivery. So what we're trying to do is make sure that that information is trusted wherever they may receive that care. Because people used to go to only brick and mortar. Now there's telehealth. Now they get their care at urgent care centers, or they get they monitor their own care through their phones and then call the doctor. So how do we make sure that that data is trusted and travels with them, leaning into what Peter says? And what I've found is that what has happened a lot is there's a huge data dump. And so this data dump, and they throw everything but the kitchen sink in there. And then our clinicians are like, whoa, we can't utilize all this data. It's way too much. We're going to go back to the facts, because what will happen was the HIM department at the hospital will fax me a nice little concise discharge summary or an ED record that has everything I need on 1 page or less, not 1,000 pages. But people get confused and they think clinicians want that. They do not want that. They want to leverage those expensive electronic health records that they've implemented, and they want to pull that information into their EHRs in a nice, lean, concise manner so that they can leverage clinical decision support. So it's exactly what Peter is talking about. It's standards, it's portability, it's trusted, it's timely, but the content is what really makes for quality, because the content is too much or too little. And all of that is dependent on the EHR vendors a lot of times, or the other app vendors, as healthcare expands its use out into the market. So we've got to come up with, what's the standard for a discharge summary? What is the amount of information? And our HL7 partners did a wonderful job getting a framework there. I mean, they're just beautiful human beings. But now that the pipes are there and we know that we can exchange information, we need to beef up the content and say that these templates need to be added. And that's what we did in Texas. We said discharge summary CCDA, that's a beautiful thing. However, we need to add these additional components to meet the clinician's needs at the front line. Did that answer your question, John?
Oh, absolutely. And I think that that's just, it's so immensely important what you said there about kind of that process for standards development and then standard iteration for it. So I have the opportunity working with several others, HL7, on both CCDA and on FHIR standards for this. And sometimes we want to just say, we did it, we wrote it, we published it, and the work is done. And you're right, it's not done. We need to always be iterating. We need to take that implementation feedback and be able to continually get that feedback loop into being able to improve the standards. and to beef up the content, just like you said, for it. It's immensely important that we get this right, and to build that trust, we're going to have to actually continue to deliver more than what we're doing today for it. For the next one,
thank you, John, for letting me. One of the commenters in there felt like that. I felt like the HEMA naming framework was the end all to be all. I think that it's a wonderful start, and we at HEMA believe that we've updated it once, we will update it again, because you have to start somewhere, and incremental improvement is better than no improvement. My philosophy in life is 7 times nothing is still nothing. So you need to constantly be making things better, and not to say, well, I've done this, I don't have to do any more. Our lives are not over. We need to keep going.
Absolutely. So I'm going to go next to Stephen and to Sandy here for it. So, picking up off of what Peter said there, fit for purpose is part of the definition, part of the understanding for data quality for it. What are the common purposes? What are the most frequent use cases that you're seeing for data quality and clinical exchange today for it? And how are we doing? What's the best, use case that we're fulfilling? And what's the one where you see big gaps for opportunity? Maybe we'll go Stephen first and then Sandy.
Sure. Well, I'll lean on all the work that's gone into TEFCA. I think the purposes, the low hanging fruit, have been laid out. It's treatment. That's where we've had the vast majority of our success in interoperability today. I mean, I, as a provider, enjoy the benefits of that interoperability every day, but I talk to providers in small office practices, safety net hospitals, rural communities, talk to folks who are not physicians, who are out in the community trying to care for patients, integrating dental data or, chiropractic data, you name it. I mean, so treatment is where we've made the most progress, and yet there's still lots to be done. Individual access, clearly an important area that ONC and others, CMS, have been driving for years now, and it's right there, to be part of the very beginning of the implementation of TEFCA. But the other use cases, the payment, the healthcare operations, the public health exchange, the benefits determination, and then on down the line, research, et cetera, there's a lot of uses of this data. And I really like the way Peter, characterized and separated out data profiling, just being, what can we say about the data itself, separate from the use case, right? Because we have to think about both. We have to raise the quality of the data so that it can be used for any and all of these use cases. I mean, we're seeing that more and more, with USCDI. USCDI is not advancing to meet a specific goal. It's pointed to by CMS, by TEFCA, by the Health IT certification program. It's meant to be multi-purpose, right? So it's one tool in our kit. I think with data quality, we need to raise the profile, I don't know what the right terminology is, of the data itself, and then we can use it for all these purposes. And we may get the data to a certain level, and it may be good for these 6 purposes, but it still doesn't quite meet these others. And again, it's the model of USCDI plus. It's like USCDI does so much, and then there are these other use cases where we need more, right? And I think the same is going to be true for data quality. But we have to start, and as I said earlier, we have to agree. We have to come up with a common set of metrics and dimensions that we're going to monitor and improve upon if we're going to really make progress.
Yeah, no, I mean, what Charlie said earlier about just having something to measure is kind of the starting point for this whole endeavor. That's actually partly, I think, why it feels so bad sometimes about where we are in data quality, because it felt better when we didn't measure it, where we didn't have metrics and we didn't know how bad it was. Now we can see Charlie's work, we can see Sandy's work, we can see, the patient matching things that Catherine said. And once you expose these issues, there's a little bit of frustration, there's a little bit of pain with it, but it gives us something to measure and then to continue to make improvements on. Sandy, obviously Stephen touched on the treatment as one of those primary use cases, and that extends to the Veterans Administration and to the Health and VHI, the Veterans Health Information Exchange for it. I'd love to hear your perspectives on that as one of the purposes, the fit for purpose aspects of data quality, but also the other ways that you see this data being utilized.
Right. And I agree with Stephen and everything he said, but I think there's a component we're missing you know, coming out of being a clinician myself, that we're working toward patient-centric healthcare. You're asking me to own more of my healthcare. I personally have 5 portals from the same EHR vendor. Now, I've linked them, I've done all I can do, but it didn't integrate them. So I still have to go with my professional hat on and my IT hat on, and I have to explain I'm here as a consumer of my wellness visit, and yet, you know, here's a piece from here and a piece from there. I don't have an integrated record that I can share with anybody to say, we got some problems going on here, some speed bumps. Could you help me through them? But I think the patient-centric part is a use case that's not fully fleshed out. And I think we need, if we're going to make me more responsible for my healthcare, then you have to invite me in and give me a really big use case out here.
Absolutely, here for that. And I think we all experience this. We're all patients. You know, we all feel the pain of having to log into multiple portals, whether they be, you know, the Epic My Charts or they be other things for it. You know, none of us can get all of our care from one place anymore. So it's just a fact of life that we have to do this. And, you know, we've made great progress. I've got more health data on my phone than I've ever had before, but is it deduplicated? I had a friend recently that was using Apple Health Kit and was bringing in their vital signs, and they said, you know, all I wanted to do was graph my weight over time, but I got 2 providers that do kilograms and 2 providers that do pounds. I can't do it for it. So that patient-centric aspect of things is absolutely there. You know, Stan, I'll go back to you just a little bit further. How far do you think we have to go on this? You know, what are the next meaningful steps towards getting towards that?
I would think, you know, opening the door to the patient consumer, you know, what their needs are and understanding it better. But I think we're a long way off because, you know, I'm a pharmacist, but I still look at some of my displays and I'm baffled. I have no idea what's going on. I can't trend it. I can't understand. And they're missing 4 procedures I've had over time. Well, I know I entered them. I went in and wrote them down on paper, at least 10 different times. And somehow they didn't get it. I even went into my portal and entered them myself. So I think, number one, I don't think that clinician education has enough informatics on a common sense level. I know that pharmacy requires some informatics. Nursing does not require a lot of informatics in their training. So that I don't think that clinicians, when a new EHR is coming in, they pick the high energy people who may have no informatics training. And so they answer the questions the way they're guided through the process without pushing back and saying, no, I have informatics principles. I understand this and I need to push back. So I think that you have to start with the clinicians getting solid foundations at base level degrees. And then I think there's a level of awareness for the patient. I've always considered myself a consumer when I walk in the door. And I know so many people that I say, write your questions down, take them in. You've got to get them answered, because when you get in the office, you just kind of panic. You go blind, you forget what they say. They give you a sheet of paper. It's ridiculous what is given to me at a physician practice. And I'm supposed to have several degrees that should make it really easy for me to use. So I think base level awareness.
If remembering our entire health record is hard for us, the 7 of us, for it, you can imagine patients who don't spend all their time on healthcare data for it. No, this is absolutely spot on, Sandy. Going to Dee and Charlie next for it. So one of the things that kind of emerged through this discussion today for it is kind of this dimensional. And Charlie, I loved your kind of breaking it down into all those different categories from a data quality perspective for it, but the dimensions of data quality for it. I'm going to ask you to, this is unfair because all of them are important. I'm going to ask you to pick a dimension that you think is the most important, or maybe the one even that you think we can make the most progress on in the next year for data quality, and how do we get there for it? I'll go to Dee first and then Charlie.
Great question, and thanks again for the opportunity. I'm going to use this as an example because somebody told me at my summit that we held yesterday, this was the best way that they've heard describe the difference between data quality and data usability. That is one aspect to data quality. We've heard everyone talk about that here today, and Charlie even so. My, of course, one is going to be usability because that's what I'm championing and evangelizing. So for full disclosure, that is what I'm really focused on right now. But I do believe in it. I didn't just drink the Kool-Aid and I'm serving it up. I do think that this is the right thing to do. And I use the example, and this is taking from Catherine and what they're doing in Texas, lab interoperability as the example. So there's one thing to have data quality, meaning all the lab data that you get has the proper LOINC code or whatever relevant vocabulary is coded to it. That's great. That's high quality so that another system could semantically ingest that data and hopefully harness it and be able to provide things like clinical decision support, artificial intelligence, all of that stuff. But what happens when you have a clinical IT system that puts those lab results in alphabetical order? Doctors don't think that way. As a complete blood count, a CBC needs to be grouped. Everything, the doctors used to seeing that grouped together. But when you get IT people who don't really practice the usefulness of this data, it's slicing and dicing and serving it. So I think the two of those, quality with the usability in mind, is the best way to get forward, because we have things that are happening with the clinician burden, all these things that we need to help increase over the quality part. Like you mentioned earlier, there are over 400 million clinical documents being exchanged measurably every single month across the care quality networks. So this data is just going to keep getting more complex as you add other transport mechanisms like RESTful with FHIR and things like that. So to me, that's the most useful, but I'll turn it over to Charlie to answer now.
Well, I'm just going to make one comment on it, because I think you're so right, which is this isn't a solution that happens via standards for it, right? It doesn't matter if you're CCDA or your FHIR or your V2 for it. This is something, that usability aspect for it is something about bringing it together in a meaningful way, presenting it in a meaningful way for it. Can I go back to that informatics about reducing clinician burden, cognitive burden on the receivers of this information? It's so essential for it. I like it. So I like it. I don't know if Charlie's going to go for the same one or not for it, but Charlie, what dimension do you see as kind of the biggest one you want to call out and what we can do to make it better?
And I feel it's kind of a trick question. One of the things I was kind of doing research on the taxonomy was I kept running against, when I was searching and researching, an analogous area, which is food. And it's interesting that the data we're feeding our systems, when you look at traceability and provenance and all these things, it's like food. And to get something to be quality and edible, there's a certain amount of energy you have to invest into it. And the same, like, it's pretty easy to eat an apple. It's a little bit harder to eat a steak if you're starting from the source, right? You have to put more work in to have a good quality steak. There's more steps. I think when it comes to data, the dimension that's most important kind of depends upon the context of the data. And there was a question in the chat about, what does valid mean? Well, valid depends upon what it is. Have something being a valid number is important. If it's not a valid number, you can't use it. If you're trying to exchange a medication, you have to have something that is valid and then normalized to a terminology that we've all agreed upon that we're going to share. So I think when it comes to these dimensions of data quality, it always comes down to this idea of the golden rule. Sharing data. I do a lot of work within large enterprises where they're getting data from all their hospitals and clinics and pulling it together, and they have something very organized and something they're trying to do there. Sharing data through something like TEFCA or an HIE is an altruistic act. You are putting something out there, not for your own benefit, for the benefit of others. And the quality dimensions vary quite a bit based upon the piece of information that you're putting out there. So, but it all falls back into what Dee Dee said. So I'm going to rely on Dee Dee's definition and say that at the end of the day, there's no point in sharing it if somebody can't use it. And that somebody, by and large, is not a human being. It's a piece of software. Because if we just want to share with a human, we could go back to faxing, like we've talked about before. If we want to be able to share in a meaningful way with a piece of software so we can act in a way that supports a clinician who's already overburdened with everything they're trying to do, that's kind of what I always think of when I think about usability through the lens of interoperability.
Yeah, no, I think that those points are really, really well taken for it. And I know that that's a struggle on the validity aspect of things for it. You know, you can have a perfectly conformant LOINC code for systolic blood pressure for it, and you can have the value be in milligrams of mercury. And if the value is 12,080, 12080, is it a valid systolic blood pressure? No humans ever had a blood pressure that high for it. And you know what's happened here, right? So they meant to write 120/80. And they just got concatenated into one field rather than being in the systolic and diastolic fields for it. You know, the validity, it has to go, you have to kind of do double clicks to get at what you're talking about in the context associated with that, but it has so much to do with the usability of that as well. So I'm going to stick with Charlie and Didi for the next one here. We're going to do a little bit of snake order here in terms of going around with questions. We've touched on standards and we've touched on how they relate to data quality. We often use standards. We use things from HL7 or other standards development organizations to talk about data quality. Charlie, on your slides, I saw some HL7 too. A little bit of the OBX segments for it. Didi, you alluded to CDA for things. We all hear people talking a lot about FHIR now for it. I'd love to just think about all the standards that are out there: HL7 V2 messaging, CDA, FHIR, scripts, ASCX 12 with billing information for it. I'd love you to comment, where do these standards kind of shine and where are they less optimal? Where do we have high quality and poor quality by different standards for it? Or do you even think it matters, which standards you're using when you're talking about data quality? I'll go Charlie first.
Okay. So I think when it comes to standards, interoperability, I always say there are 4 factors interoperability. There's physical interoperability, which we pretty much mastered in this day and age. There is canonical interoperability, where we take the way we naturally organize and think about the data and transform it into a more generic canonical pattern. There's syntactic interoperability, where you put it in a message with a particular format. And then there's the semantic interoperability, where you make sure people understand what's in the package. When I think about data quality, the challenge we have with any standard, and maybe FHIR is a little bit better than others, is it's like in Pirates of the Caribbean, where they talk about the Pirates Code, and it goes, well, it's more like guidelines. A lot of the standards we have are more like guidelines. That's why there are thousands of HL7 interfaces and hundreds of CCDA interfaces. And we're already seeing variations in FHIR. And if you look at OMOP or CDISC, the place where you don't see variation is like X12, because you don't get paid.
Yeah.
So I think that one of the challenges we have with any standard is that in order to support the flexibility of how healthcare tends to evolve at the edges, we tend not to lock down a standard and say, this is how it must be. And as a result, the standards start to have a lot of variability. And instead of going back to somebody and saying, no, you have to fix this, we build interfaces that remediate the standard or the variation of the standard. When I think about data quality, I can give you beautiful data in an HL7 payload. I can give you beautiful data in an OMOP payload to the requirements of OMOP. So I kind of think that the two are orthogonal in a way, where I can give you beautiful data in a pipe delimited text file. So I think that data quality and a format are not necessarily locked together.
Yeah, no, I definitely, there's a little bit of channeling of people at HL7 for it, which is, there's a kind of a saying out there. I won't attribute who says it the most for it, but FHIR won't solve your data quality issues for it, which is fundamentally trying to pick any of these standards to be a winner for it. These are things that can be done well in any of these standards, but there's downsides as you see that. Didi, obviously from a Sequoia perspective, from an eHealth exchange, from a national perspective, you obviously get to see a lot of these things. Any things that you call out as you look at the different standards and kind of where we are today versus where we might want to be in the future?
Well, these are just some observations that I've had the opportunity to have. Just the Texas example, going to Catherine, because we've been working together a lot on this. She brought up the whole discharge summary. The basis for the discharge summary in a CDA document started in 2005. and to be honest, really hadn't been adopted very well until the last 3 or so years. So the standard, the actual family of CDA documents, for anybody who knows CCDA, the consolidated CDA family that the US kind of put out, that has actually 15 different document types if you count all the patient generated and all of that, you know, there were certain required discharge summary sections and so forth that were not included in what was in the base spec, but Texas and all of their hundreds of organizations came together and said, these are things we want. The CDA base type of standard is an open resource, you know, functionality. So all templates are open. You can slice and dice them as you want. And that is the beauty of it. So there's still evolution. And look at that. That's almost 20 years later. We're in 2023. We're 2 years short of 20 years. So I think every standard has some room for improvement. So, but on the opposite side, I'll use fire as another example. I think fire is not mature enough to do some of those quality pieces because everything's not defined yet. Not to say it won't have the possibility, and it's catching up fast, but I don't think you have the level of granularity that you have in a CDA document. And quite frankly, those are what's being exchanged for those treatment purposes today. So I think that there's some room, but I'm hoping that we can use lessons learned from V2, from CDA, from all these other, you know, NCPDP, X12, whatever, to see how we can also learn that and apply it, because it should be technology agnostic. It shouldn't be dependent just on that spec, hopefully. I don't know if that helps, but.
Oh, that's absolutely, you know, spot on. And I always try with my informatics students to tell them standards have a long tail. You know, if you think you're going to get out in the industry and you're just going to do fire for it, you might be waiting the next 20 years for it. HL7V2 and CCDA aren't going anywhere. And you're right to point out, you know, CCDA was not just the CCD. You know, often gets, for those who don't know the acronyms, CCDA is Consolidated Clinical Document Architecture. The CCD, or the Continuity of Care document, was the one document that was required at the first part of essentially the meaningful
use. Yeah.
But there's other document types in there, and there's the opportunity to even have unstructured, you know, documents be able to send information along. So it gives a lot of versatility, a lot of opportunity to play with for things. Kind of coming back, this one's gonna be a little bit of a three-parter. I'll go to Catherine and Stephen and Dee too, if you want to weigh in. You know, sometimes data comes directly from one EHR and goes to another EHR for things. But often we see that there are these intermediaries, you know, health information exchanges that aren't just routing it, but can actually act upon it to try to improve it, to try and make it better. You know, Charlie talked about what they could do to uplift, upcycle, or to make that information more usable downstream for it. You know, how do we create trust in these networks of health information exchange for it? Can you only trust it if it comes from another EHR directly in an unaltered version, or are there ways to kind of build trust in a network, you know, that's doing meaningful things and might be aggregating records or deduplicating or things like that? You know, Stephen, maybe I'll go to you first on this one.
Sure. I mean, I think we have to realize that the vast majority of clinical data exchange today for treatment purposes is through networks. I mean, the eHealth Exchange, the Epic Care Everywhere Network, Commonwealth, you know, et cetera. And then, of course, HIEs play a key role in a lot of communities where, you know, they've got years of experience, you know, building that trust. But, you know, I've been involved in the evolution of care quality and eHealth Exchange, and building trust is key. You know, I mean, it comes slowly. You have to nurture it. You have to respond quickly. But you're absolutely right. I mean, it's the minority of exchange that goes directly from EHR to EHR. I mean, you have to have a very tight use case there, you know, a bunch of practices using a hospital sort of thing to write those V2 interfaces. But that's definitely the exception rather than the rule. So, I mean, the goal that we've seen with TEFCA is, again, to even further raise the bar on trust, you know, to bake in specific security requirements, specific, you know, review by the RCE and designation by HHS. So you're absolutely right, John. I mean, it is about building trust, and it's building trust in the network, you know, components and in the framework overall, that it will be governed, that it will be participatory governance, that key participant groups will have a voice there, and that through that we'll build trust. Now, having said that, nothing is ever 100% trustworthy. I mean, there are always going to be issues that come up. There are probably some bad actors out there. There's clearly technical glitches. We're all dealing with issues of data privacy, data security, which, we can have a whole other set of, discussions around, but those run in parallel with data quality. So trust is key. We have to keep building it. But as we discussed earlier, and I think Peter made a really good point, in order to trust the data, you have to trust the quality of the data, as well as the path that it took to get to you.
Yeah, and one thing I've heard just repeated in the industry too is transparency as part of that trust building exercise for it. We don't need to pretend like our data is perfect. And frankly, we shouldn't, because that erodes trust rather than creates trust for it. We have to acknowledge that things are not perfect where we are, but let's also not let perfection be the enemy of the good. Let's continue to work that chain and work that process, take steps along that journey, as it were, for Charlie talking about trekking and Sandy as well. Catherine, I mean, what have been the things that you've seen that have been big trust builders as you've worked with being able to facilitate this exchange?
Well, I'm going to rely on my Texas Health Services Authority Interoperability Collaborative, and Dee Dee participates in the collaborative with us. And we actually look at information in what one organization thinks they've sent to someone and what the other organization receives. And we have their EHR vendors, they're partners with them while we're doing it. And if they happen to use a health information exchange, we have them there. And we look and we say, okay, well, Dee Dee thinks that she sent me this, but I am getting this. And so we talk about that transparency. Okay, EHR vendor, they're sending, but why aren't you receiving it? And I would like it packaged in this way. And that's how you build trust. Because before, John, what was happening, before we had that show and tell sort of activity, individuals would be angry with one another from hospital to doctor's office. And Dee is right, they were pointing fingers and saying, you're not sending this and I can't take care of my patients and it's your fault. And then the organization would say, I am sending it. I'm doing my best. And so we began to do that across different organizations. And guess what? We found even with the same EHR platform, different organizations had it set up different. And then we worked with the vendor partner over that EHR to make sure it was standardized and to help them consider communicating to their community the value of standardizing the output. So that has led to trust. We've also worked with our public health partners, because one of the things that we learned, and I'm sure all of you learned it with the pandemic, was the immunization registry becomes incredibly important and becomes part of the continuum of care. But our immunization team didn't interpret the standards the same way as the EHR vendors and the organizations. So we had these three different views for each and every organization on getting that data standardized and normalized so it could be ingested into the EHR and could help those frontline clinicians. So it's leaving your egos at the door, recognizing all of us have issues and we all want the same thing. The one thing I can say, John, and I think Dee Dee will echo it, is everyone wanted to do good work.
Yep.
Everyone wants patient care to improve. Vendors, hospitals, doctors' offices, public health, no one wants to do the wrong thing. So once we leave that at the door, that does create, once we all recognize that common goal, it creates trust. And we have been able to break down those barriers to safe, secure exchange of data that helps clinicians. But it's leaving that at the door and being a neutral convener.
Yeah. The neutrality for it and the passion that people bring towards this. Everyone often has that North Star of improving the quality of care, reducing its cost for it, but just getting there is hard. It's hard to go find the people who want to do the information blocking. Everyone wants to make this happen, but it's not easy. It's just not easy. And everyone knows that they've got blemishes for it. Dee Dee, I'll let you comment on that as trust as well, but then I'm going to pick up on one other thing Catherine said.
Yeah. So just, wrapping up kind of in my thought, keeping it kind of short and concise, really well-defined rules of the road. So understanding those pieces that are technical, I want you to include these sections specifically. So getting those rules of the road very well defined, so there's no ambiguities. And if there are, clarify them and reach that consensus. But really, when you mix that with a policy or governance framework that then engenders the trust, they're all playing by the same rules of the road. They also know what the consequences are if they don't, et cetera, et cetera. So I think having some of that engenders the trust, knowing everybody's doing it the same way, instead of having this V2 interface this way or this one this way, trying to make sure that we're all trying to do the right thing, to Catherine's point. But that's kind of my summary of in what my mind builds that trust, but also maintains it over time. And the feedback loop, making sure that there's a mechanism to be heard. Because I mean, Catherine, you mentioned being at the implementation-a-thon. I'll be honest, some of the work Care Quality and Commonwealth jointly published several years ago are now included in HL7 base specs, because HL7 listened and said, oh, we can improve the bases here. That's what we need to do, but we need to keep iterating. So
I agree entirely. I'm going to take that and actually package it up with a little bit of where we were going for like a feedback loop, but also a little bit about how do we provide that feedback in terms of things. One of the misconceptions that I find out there in the market, because people are frustrated with interoperability, people are frustrated with data quality, and they want to point some fingers, is they say it's that EHR or it's this provider or this technology that doesn't work for a lot of these things. But one of the things Catherine said that I found just to be immensely true, but I'd invite Sandy, Charlie, Peter to comment on this as well for it, is that you can use the exact same technology at 5 different places, exact same software version, released on the exact same date, and come up with completely disparate data quality for things. So maybe Sandy first, I'd love to hear your perspectives, because you obviously see a lot of this incoming data quality, but then go to a little bit to Peter and a little bit to Charlie.
Right. It's one vendor implementation is one vendor implementation. Their configuration, even how they display any screen, to compare two labs from the same EHR, two different institutions, it's tremendously different. The data they include, the guidance, the data kind of guides them a certain direction depending on what data is there. So yeah, one is one.
Mm-hmm. It's almost, you got to look at everything as a pairing of a technology with a practice or a facility or an organization for it. But go first to Peter, then to maybe Stephen next. I see we got raised hands here.
It's been wonderful listening to the conversation and where you're going. There's a couple of things I wanted to point out that I think may be interesting to what you're working on. Obviously, tracking the provenance of data, Charlie mentioned that, is critical to what we're doing. But we're moving into a new era of being able to define data as authoritative. So it's not just a question of provenance, but is the data authoritative? So for example, today in a commercial world of tracking organizations, we have access to about 200 countries that the governments give us access to their databases. So in real time, we can validate the true legal name, as well as what we call date of origin, which is the date of birth of an organization in real time. So we don't rely on secondhand information. All the data we receive is constantly being validated and verified in real time. And what Catherine said in terms of identity of patients, if you can imagine the ability to verify legal name and date of birth, which is date of origin, in real time in basically vital records, that changes the whole game, because now this is the official authoritative record. So that's coming. The other reason we're seeing that appearing is because of the advent of AI. Unfortunately, with AI, I think we've all learned that AI can lie. It can actually make stuff up, right? So we need to counter that. We need to be able to make sure we know the provenance of the data, and is it an authoritative source? What was the authority of the source providing the data? And that's really exciting work at the moment. It's not very hard to do, but it does open up a whole, our ability, and computers today, it's like moving to fiber optics, our ability in real time to access the data at source. So we're saying, create it one place, please don't move it, keep it there, let me get access to it, to an API or something else, but don't move it. I don't want secondhand. I don't want, residual or echoes in the system. I need to know where to go and get you. So some of our standards in the ISO standards are about how do you resolve identifiers. If you pass me identifier, passport number, corporate registration number, a birth certificate number, patient record number, how do I get to the authoritative source? The authoritative source is the issuer of that identifier. Whoever issued the identifier is the authoritative source of the data it represents. How do I do that in real time? So we have standardized APIs that make it easy to do that and to keep track of that data. It's very exciting work, and I think it's going to have a big impact on healthcare as well as other industries.
Well, I mean, standardized API is just the name of the game with FHIR for things. And that is one of the exciting things about this, which is, you're right, there are a lot of echoes in the system, right? Data gets perpetuated, copied and copied and copied. I have a colleague that talks to me about how 20 years ago, one doctor put down in the medical record that he was allergic to penicillin for it. And as a consequence, he can never get prescribed penicillin, ampicillin anywhere he goes for it. He's never had an allergy to penicillin for it, because that echo chamber has happened, and it's kind of perpetuated through many, many different records. But FHIR gives you a standardized way to access allergies, allergy intolerance resource on a real-time basis for it. So you can actually do things like say, hey, this was entered in error for it. And you can actually see that while it was there and it was real at one point for it, it might not necessarily be real today. One of those dimensions is timeliness of data, which I just think is immensely important as well. Stephen, I know you had your hand up too, and I'd love Charlie's perspective on this as well. Stephen, you're muted.
Much of what I was going to say has been said, but your point about the allergies, this happens all the time in practice. A patient will come in to see me and they'll want to update their record. And I can do that, in my record, if I have the time, fix the problems, the meds, the allergies, what have you. They say, I've been telling the nurse this for the last 5 visits and no one's ever done it. Well, that's my colleagues, they haven't done it, but I can do it. I can fix it. But that doesn't mean that it goes out across the ecosystem. I mean, if somebody queries me again, they'll see my updated record. But there's no repair process. There's no way for us to say medication reconciliation. Here is the reconciled med list as of Thursday afternoon, and the patient approved it, the PCP approved it, the pharmacist approved it. It should be sent out to everyone, and they should take that in and say, okay, this is the approved version. We don't have any plans to go there, but we need to, because again, data quality, as you say, there's so much diversity. We can try to repair it in our receiving system, but as I keep saying, we need to go back to the source for both the quality and the accuracy of the data. And it's going to be a big problem.
Yeah, no, in provenance, and one of the things that you said, which is just carrying along that original data, it's just so vitally important as you do this and you pass that data along. Charlie, love to hear you weigh in on this as well.
I think going back to what you said originally, there's like a handful of issues when it comes to each one of these systems being the same system, the same vendor. One of the things you see when you look at some of these systems is the people that are building the dictionaries within those systems have a lot of power. How their vocabulary practices, their skill, their training, their understanding what a concept is and what a concept isn't is one thing. One of the things that's a little bit concerning in healthcare today is as people buy more commercial off-the-shelf systems, you're seeing less and less clinical informaticists having jobs within hospitals and systems like this. In the old days where we had partners in Intermountain and these places that had these very rich clinical informatics teams, you're seeing some of that go away. And I worry a little bit about what that does to our vocabulary practices within these institutions. The other aspect of it is data entry. Going back to the allergy thing, I was in a doctor's visit once and I went to do a pre-diabetes check because my family has a history of it. And when I left, the note said I was there for my allergic rhinitis. And I asked the question, I didn't mention that. I think you gave this to the wrong thing. They said, oh, don't worry about that. That's for billing. That's not something that has to do with your clinical situation. This was years ago. I hope it doesn't happen anymore. But it's this idea when people are entering data, understanding how important the data is and what their skill level is, understanding the reason why they're entering the data, and making sure when we talk about fit for purpose, If I'm entering something for billing purposes, it may not be appropriate for use for clinical purposes. And that's where things tend to get, cross-wired. And it's why this whole idea of vetting and going to your flywheel concept of vetting and giving feedback on the quality of the data is critically important. And you have a question later on that you threw out there that comes into play here too. I'll save it for then.
No, you actually go for it, because we're going to only have 10 minutes here. I don't want to.
Okay, so it's basically the idea of who's responsible for the data. It's one of the trick questions I ask new employees at clinical architecture. I say, who's responsible for your data? Is it you? Is it your doctor? Is it your insurance company? And the answer is, today, it's no one. No one's responsible for your data. There is no data steward for our data. And yet we're feeding this data to analytics and decision support and machine learning and AI. And then we get confused why the results are less than wonderful. It's because we don't really put a lot of energy into proactively managing that data. And I don't think we have an idea yet in this industry who should be doing that even. It's a conundrum.
Yeah. No, I know everyone at ONC was holding their breath that you weren't going to say they were responsible for the data quality for it, but no.
Wait.
But this is where there's an intersection between vendors, patients, regulations, tying these things together to think about that spectrum for how you get towards a higher data quality. Peter, I'm going to go to Sandy for one more thing, and then I'll go back to you. Sandy, I'd love to hear, Charlie was just picking up that whole theme of the flywheel, that continuous improvement. You have to provide feedback to everyone that shares data with the VA, or at least a large number of people who share data with the VA for it. What have been some of the most effective things you've done and you found as you share data quality findings back to those sources?
I think to go in with curiosity, that they did not think that we were coming with judgment. And we always say, tell us what your findings are about how we're giving data to you. So it's open-ended both directions. I think that it's important to say, we're here for the patient and the clinician. There's nothing in my job that doesn't point back to making it better for the world at large. So I think this is where, again, when we get more of a consumer input into there, if you explain to somebody that your brake systems, when you go in to have them checked, you want them at 100%, but the data that's flowing through about your health, there's, it could be just about anything. And, if you're not treating yourself and the quality that comes into your institution the way you would the brakes on your car, I think we got some base questions that we have to start asking and resolve. Doesn't have to be perfect day one, but I think we need to set small markers, like Dee always likes to say, small, incremental, so that we can get there. But, the attitude of some innovation people is just, oh, turn it on and let it go. And it's like, oh, no, don't turn that on, because you haven't tested everything. And on day one, every weird little thing's going to happen. And you'll never be able to recoup from that. Yeah. So it's a measure stepping into it.
And we suffer in this in healthcare just because of the, I'd say, opaqueness of this, which is when your car brakes fail, there's a car crash at the end of this. When a plane crashes, you can see that. And when these things fail, sometimes you don't see it because, Stephen and others said, clinicians do such a great job of making up the difference. They do so much work on the back end to close that gap between poor data quality and poor interoperability for it, to make things happen for it, that we don't see this. But we know patients receive suboptimal care. We know that patients die sometimes because we've not been able to get this information to the right place at the right time for it. So there is, your analogy is spot on, Sandy, for the breaks. For it. We should accept nothing less.
They miss opportunities, a new care management program, a new protocol. And you've just qualified because your labs came back differently. You miss that opportunity. And that's what, is unconscionable, that you should have every opportunity open to you. But till we get the data organized better, it won't happen.
Yeah, but I love the curiosity too, which is not being too judgmental. Peter, I'm going to go to you, and then I got one more question as we kind of wrap up and get towards the end of our hour.
One of the things that's making a difference is really addressing issues of data validation. For example, my dentist, every year give me a blank form to fill in. I go, really, that's probably not a good way to go, because who knows if you're going to transcribe it correctly. Why don't you give me a filled in form that I can go and check the data, and if there's mistakes, fix it? Well, she's smart. She did exactly that. First, it takes me less time to do it. Number two, we actually drive out errors. And as Charlie said, when I visit the doctor, after I leave, I check that record, and if it's wrong, I get it fixed then. And I tell everybody I know, do not leave. That's why you get that document. Read it. If it says you haven't got the right drugs, get it fixed then. And Stephen, you mentioned about immunization records. I'm not so sure they should be distributing those records. I'd rather have a single source, and we use an API to go and get them. So yes, you go and fix it once in one place, and that's where it saves it. And you go in and check it. You go look at your record. You make sure your record's correct. You're the interested party. You're motivated to make sure it's correct. So the best practices in data validation to engage if it's not the authoritative source, at least a knowledgeable source. The patient doesn't see many other patients' records except their own, but they know their own records, and we're not getting that feedback into the healthcare system. They're not really paying enough attention. Shai says, don't worry about it. It doesn't. Yeah, no, I worry about it. I'm going to stay here until you reprint another copy and it's right. I'm a pain. That's the way it goes.
No.
So validation is really important.
You hear both sides of this, which is you hear clinicians sometimes say, well, I don't necessarily want to trust data that's generated by a patient for it. But every time they hand you a blank form, that is patient-generated data for it, because it's just what you can remember at that point in time. I love that idea of starting from the base of what's there and having a patient curate rather than generate for things. So maybe the last big question that we'll have as a group here, and this will be a jump ball, so let's see who wants to go for it. The two things that I think are just the most exciting about healthcare and interoperability, data quality that we're seeing here is the advancement in the standards, which is, I think, that seeing FHIR, seeing APIs, seeing the opportunity, as Peter mentioned, kind of the ability to call back to an authoritative source for it. That's just so exciting, and it's advancing at a great clip. We're seeing, obviously, things from the federal government, things from vendors, things from organizations that have brought that forward. But the other thing that we've all been awakened to almost a year now since ChatGPT came out here is natural language processing, AI, machine learning for it. And the opportunity that has in healthcare, because sometimes a lot of this data that we have is still not structured. I always liken, almost everyone's got structured, white blood cell counts and basic metabolic panels for it. But when you want to go find that left ventricular ejection fraction for a patient with heart failure, you're probably going to have to go to that note. So much of this information is embedded in text, and so much of what clinicians find valuable is text. For those two themes around FHIR and around data quality, for machine learning, artificial intelligence, what do you see as the biggest implications or the biggest impact that will have as data quality? So I'll make this one a jump ball. So whoever would like to go for it first. Stephen.
Yeah, I mean, I do think that, the information that's in textual notes can be obtained. It can be pulled out with NLP. I don't think you can trust the NLP to do that all by itself. I mean, it's better and better, but I think the idea of having a bot, a machine of some sort that pulls that out, as you said, the ejection fraction, puts it into a discrete field, and then for now, lets a human being check it, is probably the way to go, because we're human beings. We're discursive, we're prosaic, we're all the things, we're not all bits and bytes. And so we don't want to do away with free text. We don't want to do away with, subjective impressions, but we need to capture the pieces that are in there, because we also have learned that clinicians won't do double entry. They won't give you a text note and fill out a form. It's just not going to happen.
I love that idea of making sure we keep the health story alive about a patient for it, but then making that as easy as possible. You dictate, gets transcribed for it, and then maybe you have some assisted technology from AI or machine learning that says, hey, by the way, here's the updates to the problem list and the med list that probably need to get done for it. Peter, you go next.
We use AI a lot, ChatGPT a lot, and different ones. Bard is good too, by the way. But bottom line is we're finding it that if it's used by experts for them to review the results, it's very, very helpful. Used by non-experts, it's very dangerous and very destructive. And, a student trying to use it to write their essays, not a good idea. But for us, looking for better quality definitions, better readability of definitions, when we understand the context, it's very useful. But that's what's actually driving the push towards authoritative source. And that's the next generation of the AI is being able to discard sources which are not authoritative, they're actually trying to mislead, and that noise, the volume of noise, is not indication of truth. And that's one thing that AI is finally figuring out how to do it. Because we're seeing in the AI systems, I work on some of the AI systems, is that based on the data they're using to teach these systems, if the data is biased, the algorithm is biased. So you're getting biased results because of the data. So a way to avoid that is actually machine learning on smaller data samples that we know are accurate and true. As far as just, somebody says, if you throw a lot of data at it, you'll find out what is quality. There's one person that said, quantity is an intrinsic quality of itself.
Mm-hmm.
And does anybody know who said that? Lenin. Okay, so quantity by himself is a quality, but when it comes to AI, that is not the case. So we are seeing smaller data sets used for training, where there's a lot more effort has been put into making sure the data is accurate and the data is authoritative, and that's great.
Well, we're going to go Charlie, and then we're going to do a quick round robin and wrap up because I know we're already 1 minute over for it. But go ahead, Charlie.
All right, I'll be quick. I think that the stuff going on with large language models and AI is fascinating. I think it has entered the realm of the shiny object. And one of the challenges we have in healthcare is we often chase the shiny object instead of continuing down Didi's path of incremental evolution. And when I look at AI, I think our quality of data is not good enough. And when it comes to NLP, I call this NLP part deux, in that we've tried NLP in healthcare and it distracts us from actually trying to collect the data in a better way. It almost takes us to, let's just collect it the way we used to and let the NLP figure it out. And I don't know if that's a step forward or backward. Honestly, I think this guy, I don't know if everybody's got the same box as I do. I think what's exciting to me about healthcare is QHINs, because QHINs, they represent plumbing that allow us to do things at a national scale, whether it's quality assessment, so you can know for a change that you're a bad actor. You didn't realize that because no one bothered to tell you. They just threw your data away. If the QN is looking at your data and saying, hey, you have these problems with your data, and here's exactly where they are. If we could plug things in like public health into QHIN networks, looking for epidemics and things that are happening, to me, that's what's super exciting about healthcare. AI is great, but these other incremental things are much more exciting to me.
Yeah, no, I think that's the potential that we all look at for it, which is when we get our next COVID booster and we got to look at the efficacy for it. Wow, wouldn't it be so great if we could use this data that's already flowing over the wires to answer those questions? Historically, what we've had to do is look to other nations for it. And there's a tremendous opportunity because the United States has such a tremendous wealth of digital data now. Just in 10, 20 seconds, kind of concluding thoughts, I'll just kind of go around here give each person 10 to 20 seconds. Catherine, anything that you've taken away from the day as you've listened in?
Well, I've gotten real excited after hearing Charlie talk about TEFCA, because I actually do believe that TEFCA and QHINs are the way of the future, and it is going to help us normalize the data and put a structure in place that the content is consistent and standardized and that people can utilize the information, because that's the piece that's missing right now. The pipes are here, but no one's really controlling the quality and the data integrity and the content. And I think that TEFCA and the QHINs can help us do that. I'm very excited.
Trusted exchange framework and common agreement. I'm going to give that for everyone who doesn't know TEFCA for it. Definitely take a look to look it up. I'll go Didi next because you called out to Didi a little bit.
So I'll just wrap up. I agree with everything everyone has said. They're wonderful comments. I think the real goal is truly doing what is in the best interest and thinking of it holistically. What can I do? Every one of us can make a change, and let's all figure out what that little baby step that I always say can be, that we can make one change. If all of us take little baby steps, we're going to get there a whole lot quicker and learn from each other as well. So,
Sandy, go to you next.
I say embrace the journey and invite more people on the journey with us, because we're missing some people on this journey.
Yeah, no, it is. It's going to have all the parts and all the people in the boat for it, because this is not something that's going to be solved just by the EHR or just by AI or just by a tech company or just a hospital. It's going to be a cooperative process for it. Peter, I'll go to you next.
I think what I'd say in conclusion to this one is be proactive in actively measuring the quality of your data. It's something you should be doing all the time, using objective measures, but don't assume your data is good or bad quality. Measure the quality of your data. So that's something you should be doing on a regular basis, and be aware of the change. So, it's not it's very objective. You can measure the quality of your data, and you should be doing it on a regular basis.
Stephen.
And I'm going to reference back to my slide that said, what can HHS do for us here? And there are a lot of things that they do. This was a wonderful discussion. I've loved it, but we need concrete follow-up. We need a task force. We need work groups that are going to define standardized data quality measures for the healthcare industry that we can all manage to.
Awesome. And then Charlie, last.
People often ask me why I didn't invent Angry Birds or something like that. And what I say is, I moved into an industry in 1987 and realized that it was full of heroes. And I think that, it's been an evolution. I think that data quality is something that is going to take all of us working together to make it happen. And I'm just really thrilled and excited to be part of the symposium today. Thank you so much for having me. And it was very nice listening to all of you. It's fascinating.
All right. And I'm going to echo that same remark for it. It was a pleasure. I mean, this is 6 of the, I think, leading lights here in data quality nationally for it. It's been an honor to have you, to get a chance to ask you all some questions over the last hour, but it's also just been a delight to listen to the presentations throughout today for it. Thank you. Thank you so much for it. I really appreciate your time, your attention, and everybody out there. This is a team sport, and we look forward to everyone playing together as we work on this journey of data quality for it. But I'll hand it back to Sarah to wrap us up now.
Wow, that was a really fast hour. What a wonderful presentation. Some of you have asked about availability of the slides and the recording. Those will be available on the ONC website, healthit.gov. We will also be sharing a de-identified version of the Q&A, and we will do our best to answer any questions left in the Q&A that we haven't yet addressed during our time together today. And just thank you so much to everyone who's joined us today, and a huge thank you to our panel for this outstanding symposium. Have a great rest of your afternoon, everyone.
Take care, everyone.
Yeah.